All right. Good afternoon. The Senate Finance Committee is now in session. And our first bill this afternoon will be 632 with Senator Hester. Okay. And Senator, let's see, you have a panel, Vinnie DeMarco, Calvin Ball, and Richard Weldon. They may come to the table. The mics are movable. You can move them up and down. Senator, you can either sit or you can stand at the podium where there's also a mic. All right. For sponsors, you take the time you need to lay out the parameters of your bill. And for everyone else, we have scheduled in 2 minutes each. And so you're now on for Senate Bill 632.
Thank you very much, Chair Kelly, Vice Chair Feldman, and members of the Finance Committee. Thank you for your consideration of Senate Bill 632, which creates a $45 million federally funded program to subsidize insurance coverage for small businesses, nonprofits, and their employees. As you know, small businesses have historically struggled to offer competitive and comprehensive benefits for their employees. As a result of their size, they're generally unable to bargain effectively with carriers and providers in the same way that large businesses can. As a result, small businesses are restricted to smaller, less stable, and less healthy insurance pools. To put reliable and affordable health care within the reach of these small business owners and their employees, the Affordable Care Act created a Small Business Health Options Program called SHOP. This program is administered by the Maryland Health Benefit Exchange and provides small businesses access to a robust set of health care options and provides federal tax credits to qualified participants to assist in covering the cost. Additionally, the gap in coverage between small businesses and large corporations is an issue of equity. As Maryland has the highest per capita minority small business ownership rate in the country, the gap in health care coverage disproportionately and systematically hurts minority-owned businesses. It is our duty as a General Assembly to reduce these disparities. Despite the gains made by SHOP in Maryland, 2 significant obstacles prevent its full utilization. First, the federal tax credit alone does not fully cover the cost of health care benefits. Second, the Maryland Health Benefits Exchange is only able to spend a fraction of the amount on marketing this program as it does for the individual marketplace. For example, in my district, the Maryland Health Benefit Exchange projects roughly 4,000 businesses may be eligible. However, only a few hundred employers currently use the program statewide. This means that just in District 9, we're leaving more than $9 million of federal money on the table. Senate Bill 632 would boost the Maryland Health Benefit Exchange outreach budget for the SHOP program to $3 million annually and provide $45 million of tax credits each year, provided there is available federal funding. In conversations with the Maryland Health Benefit Exchange, they are excited to get this program up and running. I've included some slides from them at the end of my testimony to explain 3 possible mechanisms for the program's implementation. While any of these mechanisms would work under this bill, it's important to understand how much work MHB has already put into this and how it could work in practice. As we hopefully enter the closing stretch of the COVID-19 pandemic, we can directly address the obstacles that limit SHOP's growth and provide additional high-quality health insurance options for small businesses, nonprofits, and their employees to take advantage of. And for these reasons, I'd respectfully request a favorable report on Senate Bill 632.
Thank you. Are there any questions for the sponsor? All right, if not, then we'll start with the Honorable Calvin Ball. I see you reaching for your mic.
Well, good afternoon, Madam Chair, Vice Chair Feldman, members of this esteemed committee. I'm Howard County Executive Calvin Ball, and it's a pleasure to be with you this afternoon. I'm proud to represent my fellow colleagues across the Big 8 jurisdictions of Maryland in support of Senate Bill 632, an innovative, transformative bill. Supporting small businesses, nonprofits, and removing barriers to accessing health care is bipartisan, good policy, and benefits thousands of Marylanders across our great state. The COVID-19 pandemic has further exacerbated the need for accessible and affordable health care. Concurrently, Many businesses and nonprofits have struggled to retain employees under the weight of the pandemic, let alone provide them with health care. By leveraging state and federal funding, Senate Bill 632 would provide subsidies to small businesses and nonprofits and ultimately decrease their cost of providing health insurance for their employees. I'd like to commend Senator Hester for introducing Senate Bill 632 and her consistent advocacy for small businesses and the residents of our community. Additionally, I'd like to thank Vice Chair Feldman and Senator Benson for their co-sponsorship and support. Partnerships between government, public, and private sector stakeholders will help Maryland residents receive necessary routine and preventative medical care for themselves and their families, and ultimately save us all more money. During the open enrollment period, more than 181,000 Marylanders enrolled in a qualified health plan for the Maryland Health Benefit Exchange, including more than 11,000 Howard County residents. In Howard County, we had an approximate 9.6% increase in enrollment over the previous year. Senate Bill 632 would assist roughly 75% of Howard County businesses with fewer than 20 employees, and that translates to more than 7,400 businesses in Howard County alone. Last year, not only was Howard County the only county in the northeastern United States to receive the prestigious National Cultural Health Prize from the Robert Wood Johnson Foundation, we were also ranked by U.S. News and World Reports among the top 10 healthiest counties in our nation. While we're proud of these accomplishments, there's always more work to be done. We will continue to support efforts that remove barriers to care and expand access to affordable health care insurance for all. Senate Bill 632 will be another step in the right direction for Maryland families, small businesses, and nonprofits. On behalf of County Executives Alsobrooks, Elrich, Gardner, Glassman, Olszewski, Pittman, and Mayor Scott, we appreciate your partnership and would respectfully ask for a favorable report for Senate Bill 632. Thank you so much for your time and attention.
Thank you. Are there any questions? Let me ask, because I haven't had a chance to actually read the bill yet. Would this be limited to the Big Eight, or would this be statewide?
It's statewide, Madam Chair.
All right. Any other questions? Okay. We'll go then to Richard Weldon.
Thank you very much, Madam Chair, Vice Chair Feldman, and members of the Senate Finance Committee. My name is Rick Weldon. I'm the President and CEO of the Frederick County Chamber of Commerce and the Vice President of the Maryland Association of Chamber of Commerce Executives. It's in that capacity that I'm here today to encourage you to support Senate Bill 632. Hundreds of small businesses would benefit from this bill by allowing the owners to offer health plans to their employees, which would then build loyalty between the worker and the business owner, while also increasing the number of covered lives and expanding the reach of our great Maryland Health Benefits Exchange. Further, nothing about this incentive undermines our carefully crafted small group marketplace, something I know is very important to this committee. Our small businesses across Maryland have been battered by the pandemic. Now they're facing new challenges resulting from trying to rebuild a workforce. Senate Bill 632 will directly address that challenge while expanding the number of working people who'll be able to join the ranks of the insured in Maryland. I had the great good fortune to serve on the House Health and Government Operations Committee along with Senator Benson from 2003 to 2009. During that time, I worked with members of this committee to expand access to health insurance and to build one of the best small group markets in the whole country. I'm proud to continue that work as a chamber executive. I pledge all of our network of chamber executives at county and local chambers across the state to this important work. So on behalf of the Maryland Association of Chamber of Commerce Execs, I urge a favorable report on Senate Bill 632 and thank Senator Hester for her sponsorship. And Madam Chair, if I finished within time, this is the first chance I've had to thank you for 2005. House Bill 935, the Relative Caregiver Act of Maryland, would not have passed were it not for your wise counsel and sage advice. So I wanted to make sure I said thank you for that.
Thank you. Thank you. Okay. Any questions of this witness? Okay. If not, then we're going to Vinnie the markup.
Thank you, Madam Chair, Mr. Vice Chair, and thank you, Senator Hester, for putting in this bill. I echo all the comments made, especially our wonderful County Executive Calvin Ball on behalf of all the county executives, as he said. And I want to thank Rick Weldon for being here. I remember in 2007 watching Rick Weldon help to enact the Working Families and Small Business Health Care Act of 2007. He was a Republican on the Health Government Operations Committee. That bill passed unanimously, and that created a $15 million a year subsidy program for small business, which hundreds of small businesses took advantage of. That was just one of many bills which this committee and the whole General Assembly has enacted to make Maryland one of the 5 best states in the country in health care. But as you heard from Senator Hester, that 2007 law was phased out with coming in of the ACA and the tax credits, which have not really been able to replace it. So we need a resuscitation and rebuilding of the 2007 law that you all, including Rick Weldon, helped get enacted then. And we think that this bill by Senator Hester does that. It will build on all the success you've made. And as you all know, when anybody gets health care, we all benefit. And thank you, Senator Benson, Senator Feldman, for being co-sponsors. We will all benefit from this bill being enacted, and we hope that you can support it. Thank you very, very much.
Thank you. Are there any questions of this witness? Senator Augustine.
Thank you, Madam Chair. Just for my understanding, because I thought I read this, but are these federal funds, or how does this work? I mean, how does the money, the subsidy work?
Well, the way the statute, the way the bill is written, it authorizes up to $45 million a year. The bill says to come from federal money or other money is available. But we would hope that it would come from federal funds. It is simply an authorization up to $45 million for subsidies and $3 million for outreach.
Okay. Yeah, no, I think that it sounds like it makes sense. I think there was a question about the money that would be available that was offered by MABE, I think. Is that correct? There was a question about from MHBE, the Maryland Health Benefit Exchange. Yeah, just about the availability of the money in order to be able to do it. So it's primarily the hope is that it will be federal money.
That's the hope, but the language. I mean, Michelle Everly, of course, is here, and they have not taken a position on the bill, but we did run the language by them to make sure. And I want to emphasize that we think this exchange is wonderful, and the 2 limits in the bill are employees, less than 25 employees per business, and a 5-year sunset. Other than that, we're leaving it up to the exchange to figure out the parameters.
Thank you.
Okay, and since Vice Chair Feldman co-chairs the exchange, I've asked him if he has a comment.
I don't co-chair the exchange. I think Michelle Everly back this that. But, okay, Vinny, just because, let's just get it out since you're the, sponsor panel. The potential impact on small market, the issues come up. And I know Michelle Everly is back there, just information. I don't think she's even a witness here. But, and I know Rick Weldon mentioned, could you just, for the benefit of the committee, could you just maybe give a little more meat on the bones? Because to the extent there is pushback, it would be there is the potential for impacts on our small group marketplace. And since you're here, let's talk about it.
Sure. We believe, and Michelle can address this much more clearly than I can, but we believe that this will have only a positive impact on the small group market. All it does is provide subsidies to small businesses that are now unable to enter the small group market or having a hard time staying in because of the high cost of health insurance. It would not in any way undermine the small group market either on or off the exchange. That is our understanding. It's simply to make that program work better, just like the 2007 law. The 2007 law did not undermine the small group market, and it only made it better, and this law would do the same.
Yes, Rick, if you want to say something real quick.
Senator Feldman, if I could just add one thing. For the last decade, you have seen people from the organization I'm representing today, the Association of Chamber of Commerce Execs, testify before this committee on an association health plan bill. When I took over as vice chair of the Maryland Association of Chamber Execs, I said, well, look, I got to tell you guys, I'm never going to testify before a legislative panel or support the idea of association health plans because I think they will dismantle the protected small group market that we've so carefully constructed over the decades, which is why I'm here and proud to be here on their behalf today to support this, because we feel like it has the protections necessary to not undo the great work that's been done over 2.5 decades to protect that small group marketplace.
Thank you, Madam Chair.
Okay, thank you very much. Okay, that's it for this panel. We'll next go to Jamal Lee, to Henry Bogdan, Amber Hyde, and Willie Flowers. I see Bryson has an amendment. Okay, you have 2 minutes each. You may go in whatever order you like, and the mics are movable.
Okay, I guess I'm it. Thank you, Madam Chair, members of the committee. Henry Bogdan for the Maryland Association of Nonprofits. I've submitted written testimony. I would like to thank the sponsor and members of this committee who are on this bill. It's very important for nonprofits. We are primarily a small business sector. We have 13% of the private workforce in Maryland, but of course you realize that a lot of that is concentrated in what are referred to as the eds and meds in the state. The rest of nonprofits tend to be very small employers. They are suffering the same issues from the pandemic. I put some statistics in my written testimony. They tend to have very little in cash reserves. They run very tight. And often, as nonprofits begin, the key element in whether or not they're going to survive and grow from the founding board of directors is the ability to bring on the first 1 or 2 staff positions. And today, the ability to offer health care as a benefit is really critical in recruiting and retaining staff for nonprofits. We suffered the same kinds of workforce impacts that we've seen elsewhere from the pandemic. Loss of staff because of inadequate child care. The child care industry itself, much of which is nonprofit, is suffering from loss of staff because they can't pay wages to compete with Target or Walmart, who are offering benefits as well as salaries above the starting minimum wage. We ask you for a favorable report.
Thank you. Any questions? Okay, Willie Flowers.
Good afternoon, Madam Chair. I'm very happy to testify on this bill. Thank you for the opportunity. In a nutshell, it does several things. While I'm the president of the NAACP for Maryland, I'm also I'm executive director of a small nonprofit organization. And by some strange reality, my organization received a grant to do affordable care outreach when the funding came down. But even during that period where I was hiring organizers to do that, I couldn't offer them health care. And this bill does exactly that, offers a subsidy for organizations like mine so that they can build and grow and retain staff. And it's extremely important, particularly when you have young people, or we call young invincibles, who may or may not care about health care when they young, but they'll need it when they get sick. So it helps an opportunity to retain staff and to build and to grow organizations across the city so they can do the work for the state.
Okay. Thank you. Any questions? Okay, you're next.
Hi, Madam Chair and committee members. My name is Jamal Lee. I'm a small business owner in Laurel, Maryland. And as a small business owner offering health coverage to my employees, it's top priority. I know the importance of having solid employees and having the caliber of employees that help, having that proper health care, helps us to provide in a workplace. And in the current economic climate, it's challenging to be able to have a diversified group and to expand and continue to grow when we're being stretched by every and taxed in every way imaginable. So we diligently worked in 2007 to support the Affordable Care Act to ensure quality health care for ourselves, and for my company in a most selfish way possible, and then, of course, for all Americans. This bill is a life-saving bill to me also, more on a personal note, because my wife, I remember back in 2011, I found her dying on the floor. And she was drowning in her own fluids. And we had to rush her to the hospital. But because we had the Affordable Care Act in place at that time, we didn't have to worry about where to go, if we could go. If there was a concern on finances or cost or anything of that nature, we were able to go and get it done. And consequently, you know, her life was saved. And I told her she owes me one, by the way. So, but I believe this was a major contributor in saving her life. And because of the Affordable Care Act, we didn't have to worry about whether the hospital was suitable or if we were going to be accepted. Small businesses recognize that the rising healthcare costs are some of our biggest challenges. So we're asking for a favorable report from you all and continued support from you all as our advocates to make sure that we have this bill move forward in the most effective way possible. Thank you.
Thank you. Now, we have a witness coming up next with an amendment, so don't all of you guys go away, because if later you have anything to tell us about the amendment, you want to know what the amendment is about. So at this point, then, Bryson Popham is next. You guys may leave the table if you'd like, but, okay.
Thank you, Madam Chair. Mr. Vice Chair, members of the committee, Bryson Popham appearing before you today on Senate Bill 632 on behalf of the Maryland Association of Health Underwriters, and also as one who has, respectfully, I think, more experience with this issue probably than just about anybody in this room. I am requesting an amendment on the bill, and honestly, the amendment is to convert it to a study bill. The reason for that is the bill is just not ready for prime time yet. It is an astounding bill in its scope, $45 million into the small group market. I applaud that. My clients and I have supported the expansion of health care and health insurance since 1993 when small group was reformed the first time. But the way this bill does it is impossible to discern. For example, I read the bill several times. Would the subsidies apply equally to small group business written in the exchange and outside the exchange in the current small group market, where there are 250,000 people currently getting their insurance? It's not clear. I had a conversation with Executive Director Eberly before the hearing, and she can speak for herself, of course, but I expressed that view to her. It certainly would need to be clarified. And by the way, let me just, as an aside, say that having been there at the birth of the exchange back in 2011, 2012, when it crashed and burned in 2013 and 2014, it is a well-oiled, well-running machine today. I can only praise the job that Ms. Eberly is doing with the exchange, and that's proven by the fact that my clients use it frequently. It does a great job with individual health insurance. Its role in the group insurance market is one that needs to be carefully examined. For example, I'll just give you one other example because I know I have limited time. There is a statute in the insurance article under the exchange title, the Shop Exchange Navigator Program. These are the people at the exchange who deal with customers face-to-face. And the language there says, and I'll read it, with respect to the market outside the exchange, the navigator may not provide any information or services related to health benefit plans or other products not offered in the exchange. Now, you may wonder why that's there. I was there when that language was put in with then Executive Director Carolyn Quattrocki. And it was because people at the exchange were offering opinions on things they knew nothing about outside the exchange. We have to remember that the people who do their jobs so very well within the exchange are unfamiliar with the world outside the exchange. Now, I would respectfully suggest, and I believe, I won't speak again for Ms. Eberly, but there is a role for the exchange in the group insurance market. It's what we call micro groups, small groups. These are people who do have trouble getting insurance. What do I mean by that? Let's say under 10, just to choose a number. Often it's 2 or 3. My own group that I have is 2. So those are the people that really need the help. That is where you ought to focus this. And while I applaud the desire of this General Assembly to continue its policy of enhancing and increasing the number of insureds in the state, we're getting down to close to that 3% magic uninsured level that we have been shooting for a long time. This bill just needs a lot more work. I pledge to help you if you choose to roll your sleeves up and work on this bill, but I respectfully believe that it really needs a thorough going examination before you enact any policy.
Okay, I'm going to ask you to sit there for a minute. Ms. Everly is in the room. Ms. Everly, would you mind coming up, giving us your take on this? If you see impediments that are structural and impossible to overcome within a few days or weeks, tell us what they are.
From our perspective, there is a great need, particularly, as Mr. Popham said, those smaller employers, 10 and fewer, the micro employers, they've really been left out of the marketplace. And the exchange over the course of the last 9 years has tried multiple paths, working with our TPAs, contracting with them, contracting with one TPA, tried many, many different programs, but that segment is still really left out. And whether it's for cost or for education on opportunities that are available. So the program has merit. I believe that the sponsors for the program left it broad enough that it could be designed to meet the needs of where the gaps are in the state. And I think certainly, as the exchange does with everything, we have lots of work groups and we don't do anything without getting full input from stakeholders and moving forward, and that would be how we would operate with this as well. And we could certainly administer a subsidy program while keeping the small business marketplace intact, which is what we all want. We do know it's hugely successful, our small business marketplace, and that's been demonstrated by really rate increases that have remained in the low single digits year over year over year, and the comprehensive benefits that are already afforded.
Senator Bellman.
Yeah, well, thanks, Michelle, for stepping up. I know you didn't sign up to testify, but you're here. So just so I understand, because this is a program that is only 5 years in duration as drafted now, or I think as amended. So just so we all, for the benefit of the committee, what happens in year 4 or 5, assuming we don't re-up, because we don't know. Part of this is to see if it works and if it were to work. What happens when the money's gone? Like, what then, how does that, from a marketplace standpoint, and the subsidies are gone? Just, could you comment on that scenario?
One thing that I can clarify is that subsidies don't determine the premium rates. So premium rates are devised and determined based by the Maryland Insurance Administration. They look at multiple factors. But as with the young adult subsidy program that we just implemented, that didn't change the premium that was approved by the Maryland Insurance Administration to charge. What it did is it afforded extra assistance to help that person have a lower out-of-pocket cost for their premium. So the rate was still, say, $200, but then the state provided an extra $30, so that person only had to pay $170 instead of the $200. That's an example. So it doesn't impact the rates, but to your point of what happens if there is no funding, and I think in our letter of information, the exchange has been clear that the biggest concern from an exchange standpoint is where the funding comes from and what happens when the funding's gone. Because when the funding's gone, it won't affect that premium that is charged, but it will affect the ability for people to have additional assistance, financial assistance to afford that premium.
Thank you, Madam Chair.
Okay. Senator Kramer.
Thank you, Madam Chair. Can you share with the committee if you all have begun to contemplate or look at opportunities or options for implementation of this legislation?
We have not at this point, other than, again, having successfully implemented additional subsidy programs in the individual marketplace. So we've got the blueprint, so to speak, and, but some of the decisions that would have to be made is, one, would that subsidy go direct to the employer? Would it go direct to the employee? So those types of decisions would have to be made, and that would be made through a study group to evaluate the best way to implement it.
And so when you say you've got a blueprint, would that transfer to this? Is that the kind of thing where it would be applicable?
So speaking from an exchange perspective, the biggest challenge for us is the technology to do that. And because we already have developed technology, it may be a little bit different. It would have to be modified and probably new technology created, but the concept is the same. Whether the decision is made to pay the insurance carrier for that amount, to pay an employer directly for that amount, pay apply it. We haven't paid to the consumer directly because it goes to the carrier, but those are just inputs and outputs, but that mechanism, we could figure it out.
Okay. Thank you. But Madam Chair, I see the bill sponsor wanted to
I saw
offer a
it here.
comment.
Let me ask you this. We're trying to get technical information, though, from the people who can make a difference here. If we were to have a delayed effective date, so there were more time for you to do the analysis necessary and to figure out how it could be implemented in a way that would be workable, do you think that would be helpful?
From the exchange perspective, we could implement quickly or at a later time. I mean, operationally, we have the staff. We've already been working on small business programs. So we have dedication of effort behind that. We've already identified some outside of this, but even just for the continued growth of small business, our efforts, some additional roles we want to add. But to your question, whether it was a delayed, we could do either. And of course, I'll just stress that, again, the study that Mr. Popham's seeking, has value. However, the exchange always does that work up front. I mean, we wouldn't implement it without getting everyone at the table and working together to figure the best solution. That's just how we operate.
Okay, Senator Augustine?
Thank you, Madam Chair. Thank you for coming up, because I really, you can help me understand this. So the request was for 45 million plus another 3 or something like that. How many people is that going to translate into, do you think?
That would be variable because it would depend on what the amount of the subsidy would be. So if we decided to do a richer subsidy amount, then it obviously would cover fewer people. I can tell you, if I'm digging back into my recesses of my mind, I think that the last time this program, when it was done through Maryland Health, the MHCC, I believe it was about, you know what, I'm not going to have the numbers right, so forget that. I'd have to get back to you, because I would just be guessing on numbers.
That's fair. I didn't mean to put you on the spot,
Yeah.
but I just, because it is a significant amount of money, I would just be curious to know exactly how many people we were actually talking about for that amount of subsidy. So, thank you. Thank you, Madam Chair.
Let me ask you one last question, and we do have to move on. If we were to get a work group together, with you representing the exchange and with Bryson representing the independent agents and with people from our General Assembly who do the policy making and the executive level work for the exchange, do you think we might be able to reach accommodations that would be sufficient before we leave this session?
I can only respond that my clients and I have an excellent working relationship with the exchange today. We would certainly give it a full-bore effort. That's all I can tell you, Senator. I think there are some complexities here that haven't been discussed in this short period of time, but they would come up during a work group, and we would give it an honest effort. One other point, if I may, you heard Michelle mention, you heard me mention, I commend to your attention perhaps reducing the scope to the micro group we talked about, the group under 10, starting there. It seems to me that would be a simpler task than the entire 25 or larger group that is called for in the bill.
Well, I'm going to ask our analyst, Patrick Carlson over here, to contact you guys and maybe at least one of the persons from the Big Eight and whomever else you think it would be, to see if some kind of a work group could, and the chief sponsor would be useful, if you wouldn't mind agreeing to be called.
Of course.
Mm-hmm. Absolutely.
Okay. All right, thank you very much.
Thank you.
Okay. Okay. We're going next to Senate Bill 621, Senator Carterman. Health insurance changes to coverage, benefits, and drug formularies timing. And you've got a couple of people on your panel, Sarah Roderas and Dana Kaufman.
Absolutely.
All right, now, Mr. Sponsor, you have the time that you need to lay out the parameters of your bill, and the other persons will have 2 minutes each.
Yes, ma'am. Thank you, Madam Chair, and thank you, members of the committee. For the record, Senator Paul Quarterman, District 2 in Washington County. Thank you today for hearing Senate Bill 621, Health Insurance Changes to Coverage, Benefits, and Drug Formularies and Timing. So under current law, patients may only be given 30 days advance notice for removal of a drug from the formula. Additionally, there's no guarantees that the services they rely on will continue to be offered by the end of their contract. This legislation would protect Marylanders by prohibiting insurers and their service plans from changing or removing benefits and drug formularies during the term of the health insurance policy. Insurance companies would also not be permitted to raise a device or prescription drug to a tier requiring the client to pay a higher deductible during their coverage. The reality here is this is a consumer protection issue. We, as in you and I, many others in their health plans, are afforded the opportunity to make changes in our health plans during open enrollment. We should know what those coverages will be there, during the duration of the plan. By all means, if something needs to change, we're not opposed to that. Notice should be given, but those changes should occur during that same open enrollment period. So we, as the consumer, would have the opportunity to make the necessary changes as well. You're going to hear from opponents today that they need to have the access to be able to make these necessary changes in regards to pricing fluctuations. Our concern there would be so the remedy is to put the full weight back on the consumer and the struggling families that depend on these coverages. You're also going to hear about the need to add or remove a drug. This bill does nothing to prohibit drugs from being added. We've drafted an amendment to submit to the committee to add services. Again, this does not prohibit adding a drug. If there's some sort of ambiguity there, we're happy to work that out, because all it means if something does need to be added in regards to different situations that come up, there's no concern there. The concern here is the removal and when things are taken away. If something needs to be removed, again, notice can be given, and the prescriber can simply just not prescribe that medication or can come up with an alternative with the patient, as we believe that decision is best made with the provider and the prescriber, and not necessarily the insurance company. You're going to hear also additionally that there's processes already in play. Federal and state law, already has a remedy for this. I would direct you, though, to a letter of support received from the Office of the Attorney General their Consumer Protection Division. And while they acknowledge that they are able to remediate some of these, there's a lot of relief, and I quote, "Remedial relief can be hard to obtain under current law." So there is an issue here that has been acknowledged by the Attorney General's office, and it's an issue that we are hopeful that this committee will take under consideration. We thank you for your time here today and respectfully ask for a favorable report.
Thank you. Are there any questions? All right, if not, then we'll go next to Sarah Roderis.
Good afternoon. My name is Sarah Roderis, and I'm a Maryland resident in support of Senate Bill 621. Thank you to the senator for sponsoring, and thank you for allowing me to testify. In October of 2013, our son Doug was diagnosed with multiple sclerosis. After 3 hospitalizations and over 4 months, the medication prescribed had built up in his system and began to work. He continued with school, playing football, even finishing his senior year as an all-county center. He's attending Salisbury University and thriving in the business program. No hospitalizations for 8 years. This past year, we went through open enrollment with our insurance provider. We confirmed that the same medication and same coverage and same doctors were included and committed to another year. 6 weeks after locking in our decision and open enrollment closed, we were notified by the insurance provider that we would no longer be able to receive his medication and that the formulary list during the open enrollment period. We began filing appeals. His world-renowned Hopkins MS neurologist also filed an 18-page appeal. Every appeal was denied. After support by our amazing Maryland representatives, the insurance provider agreed to allow Doug to stay on his medication for the remainder of the plan year. Once an open enrollment period closes, we no longer have a choice as a consumer to switch to the following plan year. I feel it's unethical to remove a medication or modify coverage once open enrollment closes. I am very much in support of Senate Bill 621 and to ensure that those providing Maryland insurance coverage make the same commitment to Maryland subscribers, just as we do in committing to the plan year. Thank you.
Thank you. Other questions? Okay, Dana?
Thank you very much, Chair Kelly, members of the committee. For the record, my name is Dana Kaufman. I'm here on behalf of MedChi. MedChi has always supported prohibiting what's called mid-year formulary changes. For the reasons that you just heard, we have many stories where patients, especially those with chronic conditions, and those are the ones who are actually affected by the mid-year formularies, suffer when they are no longer able to take the drug that oftentimes they pick that plan for. And as you just heard, unlike the insurance companies, we are unable, or consumers are unable to switch insurance companies or insurance plans mid-year. We do acknowledge that there is an exemption process. However, we do think that the exemption process does not adequately protect those who have been on a drug and are being treated effectively on that drug. If you look at the exemption process, which is outlined in the bill, it really does imply that the patient first has to fail or has had an adverse reaction on a drug in order to get through the exemption process. We do think as well, if you don't pass the full formulary prohibition change, that you take a close look at the exemption process. We have something similar in step therapy that states that if you've been on a drug effectively and for that it was 180 days because it was changing plans, but that if you are currently prescribed a drug and the prescriber states that it is effective in treating your medical condition, that you should be able to remain on that drug throughout the plan year and then have the opportunity during open enrollment to change plans. So with that, I'm available for questions. Thank you.
Okay, now you're listed with an amendment. In what way are you wanting to amend the bill?
There was an amendment offered over in the House by the sponsor, and I think I'd have to talk to Senator Corman. I thought that amendment was going to be brought over here, and it was to modify the exemption process.
I see.
To take into account if you've been prescribed and it's effectively treating you.
So really, right at this second, the House and the Senate bill aren't exactly in the same posture.
They are currently. We just
Okay.
haven't worked out the amendments of what those may be.
I see.
The House has the bill in subcommittee right now.
Okay. All right. Any other questions? Thank you very much. Now we're going to unfavorables.
Thank you.
Allison Taylor, Camille Fish, and Matthew Celentano. You have 2 minutes each.
Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente today, unfortunately in opposition to this bill. Our opposition stems from a couple of reasons. First being, we like the opportunity in the middle of a year to sometimes add benefits if something comes online. One example of that is the Biden administration required that we add coverage for COVID home test, or the test kits you can get over the counter for COVID. And so we had to implement that benefit starting January 15th. That was after the plan year began. We also think we need the ability to remove a drug from a formulary if it becomes dangerous. That's happened some in the past. I think some of my colleagues can speak to that. So we have not seen the amendment that's been offered, but would like to take a look at that and see if there could be some refinements to the bill.
Well, let me just ask you this. You heard the mother of the young man who was doing well on the drug that he was on and who was being forced mid-year to come off that drug. What's your reaction to that? And what accountability or reasonable accommodations does your company think could be made?
Well, I'd need to learn a little bit more about that situation, but that's certainly, just from what we heard today, not the type of thing that we want to see happening. We want to make sure that all of our members stay healthy. So if there's a way that we can work through this bill to make sure that our concerns are addressed, but to ensure that patients are getting the care that they need, that's certainly our number one priority.
And I'm sure you guys know what your colleagues in other states are doing to accommodate. Do you think of any other state in our region that might have handled this differently?
I'd have to defer to my colleagues. I'm not an expert on that.
Okay, all right, thanks, Allison. We'll go to Camille.
Okay.
Okay,
Good
all right,
afternoon, Madam
Matthew.
Chair, members of
Okay.
the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers in Maryland and AHIP, America's Health Insurance Plan, in respectful opposition to Senate Bill 621. Prescription drugs represent the largest segment of the premium dollar. CMS projects that the spending for retail prescription drugs will continue to be the fastest growing health category, outpacing all other health spending. The primary drivers of this cost growth are ever increasing launch prices for new drugs and astronomical increases for older medications that have been around for decades. That's a really important thing for us to understand in this discussion. It's not necessarily the big ticket items. It's the ones we've had that have been around for 30, 40 years that have no new R&D that all of a sudden go from $4 or $5 a dose to $600 a dose. If you don't have the ability to move around the formulary, we're at the mercy of pharmaceutical manufacturers' changes. One report from Credit Suisse notes that price hikes on existing medications accounted for 100% of revenue growth for 7 of the largest drug makers in 2016. It's, like I said, it's not the big sticker shock items. It's the ones that have been around for a long time. This bill would also prevent carriers from being proactive to manage costs for beneficiaries. As all of you know, drugs are commodities, and the list prices are constantly changing. Maryland already requires carriers to notify formulary changes within 30 days before adjustments, and these adjustments are crucial as drugs comes online, or in some cases, we discover safety risks to consumers. My colleague, Ms. Taylor, referred to it, but Vioxx is the one you might remember from 2004 that was pulled off the market after, in a colon prevention study, or colon cancer prevention study, it was found that the medication created a heart attack risk. This bill would prevent carriers from removing a dangerous drug from, like Vioxx, from a formulary. The bill would also prevent carriers from adding life-saving drugs that come online during the year, including treatments for COVID, including the vaccine. Lastly, the bill creates an operational nightmare for carriers, especially in the group space. We just had a long discussion about the small group market, and you'll notice, and if you have a longer discussion about that bill, which it sounds like is going to happen, is that not all group products are the same. It's not all a January to January effective date. There are October 15th effective dates starting the plan year, May 1, June 1, July 1. To try to coincide those plans is almost impossible. It would be disruptive and confusing for purchasers and consumers alike. For those reasons and more, we request an unfavorable report on Senate Bill 621. Thank you.
Let me ask this. I think I'm hearing you. If there were a drug not found to be dangerous, and in fact found to be almost essential,
right,
given the condition of a particular insured, is there a way of narrowing down the bill to make sure that people like that wouldn't be forced out?
Well,
in an untimely
under the
manner?
current law, Madam Chair, carriers can already do that. If there's a therapeutically equivalent drug that comes online that's shown to have better healthcare outcomes, we can move drugs up and down the formulary. That's the importance of formulary. We want the best acting drug that has the best health outcomes to be put to a spot that it gets out to the consumers alike. If there is a drug that is preferred by the patient, like a couple of folks have referred to already, there's a pretty clear exemption process through the Affordable Care Act. If it's a non-emergency drug, there has to be a report on the exemption within 72 hours. You have to hear back. If it's an emergency drug, the exemption process has to be taken care of within 24 hours. I would ask, if you do have concerns about this, and I'm not sure about the particular situation we heard today, but we have checked with the MIA, and we have not heard about any complaints in this space on the exemption process.
Okay. Senator Kramer.
Thank you, Madam Chair. So, Matt, we already heard, I believe, the bill sponsor indicated that there will be an amendment to allow additional benefits
Sure.
to be provided.
Yep.
So that that's not a limitation. As the committee chair just mentioned, were there an amendment to address the issue of a drug that somehow becomes dangerous, that we need to pull that back? Sounds like it could easily be done.
We would certainly be in favor of making sure there was a freedom to remove dangerous drugs from the formulary, for sure, Senator.
But I don't think that's what this bill is about, so we could address those concerns. What I think we're hearing is the consumers are locked into a contract. This is what they have to live with. Yet the insurers want to be able to make changes up and down, whatever it may be, based on pricing of pharmaceuticals at any given time.
Sure.
So they market one thing, and it sounds a little bit like bait and switch. Here's what we'll provide. Now suddenly, oh, by the way, it increased a couple of bucks. We're not interested in providing this drug that we told you was in one of the benefits in your contract. So now we're going to pull it out. Do you understand that somehow there's no equivalency, no balance for the consumer in here? So they're locked in. They can't suddenly then go and say, hey, by the way, you pulled this drug off. We don't want to be with you anymore. They're locked in. So there's no equivalency, and the notion of this total lack of fairness and parity in how this contract goes down is, I think, the reason the bill is before us.
I would respond in a couple of ways, Senator Kramer. First and foremost, when the contract is reached with the consumer and they buy a plan for the year, the insurer is not going to just remove a drug if there's not a therapeutically equivalent drug to be replaced with. Most of the drugs...
But can we pause right there?
Yeah.
And so the notion that The insurer is the one reaching the conclusion as to what that replacement drug will be, as opposed to the physician that has prescribed a specific drug for a specific purpose. That's a decision that I would be far more comfortable knowing my physician made
Sure.
rather than the health insurers making.
I can
Do
see
you-
where you're coming from on that, Senator Kramer. I will assure you that every carrier has robust review processes with their pharmacy teams, with physicians, with specialists that go through each one of the drugs. It's not like it is a person that is just looking at an Excel spreadsheet on the commodity of the drug list price for the day. It is a thorough review process that determines that it is going to get the health outcome of a drug that might be moved on formularies.
Matt, forgive my skepticism when the industry is making this kind of a decision and not the physician. I'm going to be exceedingly skeptical
Sure.
as to what the outcome is and how it's determined, because
Right.
I'm confident that 99.9% of the time it's going to be based on what's going to put more profit in our pockets rather than what's the best outcome for our consumer. And again, that's why I believe this bill is before us. But
Well, I think-
thank you. I appreciate the,
okay.
thank you, Madam Chair.
Okay, thank you. Let's hear from Camille Fish.
Thank you very much. For the record, my name is Camille Fesh, here on behalf of PCMA, the Pharmaceutical Care Management Association, which is the national association that represents PBMs, or pharmaceutical benefit managers, which is the pharmaceutical benefit that usually goes with a health care plan. We are here respectfully opposed to Senate Bill 621. A lot of the points I was going to make have been covered by my colleagues, so I won't bore you by reciting it all. First off, safety. The Vioxx example was used. We need the ability to pull drugs that have become or are discovered to be dangerous from a formulary, even though that's mid-year. It would be unconscionable if we had to if the PBMs had to keep a dangerous drug, a known dangerous drug, on the formulary for several months or weeks. Two, in terms of adding particular prescription drugs to the formulary, one of the major reasons that formularies change is when a therapeutic equivalent, a generic, comes online. The PBMs need the ability to add the generic drug to the formulary and move the brand to a higher tier, thereby incentivizing physicians and patients to use a therapeutically equivalent but more cost-effective drug. So without that ability, that hurts the ability of the formulary to really ensure that cost is being spread among all of its members equally, or as well as it could be. Lastly is cost. PBMs are working with usually the large employer that is creating a plan to manage cost for the patients. One thing that we need to note is that at any time, pharmaceutical drug companies that make these, and this was referenced before, they can change the price of the drug. And those drugs can go up at any time, the price of the drug. And we see every year that the cost of pharmaceuticals, even ones that have been around for a long time, those prices increase. And the PBMs do need the ability to move those drugs around the formulary and the tiers, because if they are stuck with a frozen formulary, it'll hurt their ability to negotiate with pharmaceutical companies and their ability to provide for a reasonable cost, for a reasonable premium, the pharmaceutical drugs that the population within the plan is using. So for those reasons, we respectfully oppose, but we are open to looking at any amendments that are proffered, working through them in good faith, and seeing what we can come up with.
Let me ask you this.
Yes, ma'am.
If the PBM has a hidden relationship with the manufacturer of the drug, such that the PBM is going to benefit financially in some way by moving everybody that they have a contract with to the new drug that they decide they prefer, what can the local medical let me put it this way. I keep worrying about relationships between the entity making the decision, with the authority to make the decision, and the entity that they are related to that might be forcing them to some degree because of interests, financial interests that they have. And I keep wondering, the pharmacy benefit, literally, don't you, well, I guess you don't, but a lot of us feel that pharmacy benefit managers just make everything more costly, and I can't see the value that they really add. You want to do that?
I think what you present is an interesting question, which is different incentive structures and different relationships across the pharmaceutical drug supply chain. PBMs do not purchase drugs. They provide the reimbursement to the pharmacist for providing the drug to the patient. So the PBMs never touch the drug, they never purchase it, so they don't have that relationship. There are other relationships that we have seen. For instance, there are wholesalers that do own what are called PSAOs, that do contract on behalf of independent pharmacies, and we have seen some issues, there have been some lawsuits, issues between the PSAOs and the wholesalers perhaps being in the same company, that do create negative incentive structures for independent pharmacists, which then can affect the whole drug supply chain.
But
So that is something we are concerned about, because PBMs are in the business of creating a product for the health insurance and for the entity that's contracted with the health insurance company, and also to reduce costs across the board.
Except they give a lot of incentives, financial incentives, to a lot of people in the business, from practitioners to folks who are the pharmaceutical folks, to do what they would like to see done. And that must be to increase their own profits.
Well, a lot of the pharmaceutical companies have a lot of those practices of giving money to physicians for talks or for amounts they prescribed. A lot of that has already been made inappropriate by federal and state laws.
It's
And that's what
not,
the pharmaceutical companies.
it's not very effective at the level that it is right now. Okay. Any other questions? All right, thank you very much.
Thank you.
Okay. Are we going next to Senate Bill 728, Senator Lamb? And let's see, you've got a panel, George Escobar, Allison Taylor, Aaron Dorian, and I guess Michelle Everly. If those people could come to the table.
Yeah, if they could come to the table. I'm not sure. Yeah.
Well, whichever of them is here, would you come to the table?
Right. I think Ms. Everly's here just for questions, so.
Okay.
All right. So thank you, Madam Chairperson. Happy to be here on Senate Bill 728. For the record, Clarence Lamb, Senator in District 12. The pandemic has shown, if anything, that Maryland's communities are healthier and stronger when everyone has the resources that are needed for themselves and for their families. And since the adoption of the health benefit exchange by the state in 2011, the state's uninsurance rate has been cut in half, and in recent years, hundreds of thousands of Marylanders have successfully obtained coverage through the exchange. Despite this success, however, more than 300,000 Marylanders still remain uninsured, and it's clear that more work needs to be done. While the state has made great strides in providing access to affordable health care, the largest uninsured population that continues to be left behind are the individuals and families who are undocumented residents. While multiple states have established programs to extend health care coverage to undocumented residents, Maryland lags behind in taking tangible action to provide affordable access to health care for this vulnerable population. In Maryland, it's estimated that there are about 275,000 undocumented residents, and nearly half of them do not have health insurance, and that's a fairly substantial amount of those who remain uninsured here in the state. So as a result, I'm introducing Senate Bill 728, the Access to Care Act, in order to expand health care coverage and accessibility to this large uninsured population. The bill would expand access by opening up plans on the Maryland Health Benefit Exchange to all Marylanders who meet the regular Affordable Care Act eligibility requirements, regardless of their immigration status. The bill would also create a framework for establishing a state subsidy program in order to help make health plans offered through the exchange affordable for this population. The federal government currently allows emergency care coverage for all U.S. residents through the Emergency Medicaid and under the Emergency Medical Treatment and Active Labor Act, better known as EMTALA. But emergency care is far more expensive than regular primary care and without the continuity. Generally speaking, undocumented individuals are receiving care much later in the course of their illness, which drives up expenses for hospitals and healthcare systems. Access to routine preventive services leads to greatly reduced healthcare utilization and costs in the long term. And we know that rates of hospital admission for preventable conditions are higher among undocumented individuals. By opening the Maryland Health Benefit Exchange to undocumented residents and thus expanding the access to affordable and preventive care, health issues and diseases in this population can be diagnosed and treated earlier before they become more costly and before they become serious or even potentially deadly. So while this bill is necessary because it's the right thing to do, in my opinion, the potential healthcare savings, cost savings are also clear, and importantly, this bill potentially has the ability to save many lives. It also creates a framework for establishing a subsidy program to help make those health plans affordable to the population that would now have access to care. The subsidy program created for these individuals would mirror income requirements and other elements present in those subsidies made available to the broader population. We are looking at expanding the definition of a qualified resident who is eligible for assistance from the state subsidy program. Specifically, a qualified resident would refer to an individual, including a minor, regardless of their immigration status. And at the time of enrollment, this individual must also be, 1, residing in Maryland, 2, not be incarcerated currently, and 3, not be eligible for any other programs like the Federal Premium Tax Credit, the Maryland Medicaid Assistance Program, Medicare, or the MCHIP program, or any other employer-sponsored minimal essential coverage that's offered. I would like to add, rather, the proposal for this bill is mostly informed by the work of the Maryland Health Benefit Exchange itself. I think over the last year, there was language inserted into the JCR to help bring forward some data information. And we've engaged directly with members of the exchange to carefully prepare a solution that provides people with access to care while also providing benefits to the state. So if enacted, we can expect to see an increase in the overall enrollment of individuals on the exchange, which in turn would help reduce overall individual market premiums by almost 4% by 2028, all while bringing down the state's total percentage of uninsured. So just to be clear, this is a win-win situation where by allowing these individuals who are otherwise uninsured to be able to seek coverage on the exchange, we would be able to reduce the number of people overall uninsured in the state, thus reducing the overall insurance premium for everyone because there's uncompensated care that's going on currently, regardless of whether someone has health insurance or not. The lower overall premiums will lead to savings in federal subsidies for existing exchange enrollees, as we alluded to, which Maryland could also capture in pass-through funding through a 1332 innovation waiver through Medicare, or CMS. Maryland has previously applied for a 1332 waiver of the Affordable Care Act back in 2018 and received approval, which was partially able to finance a state reinsurance program, and many of the members of the committee who were here then probably recall that. So that's been successful in funding our reinsurance program. Undocumented Marylanders deserve affordable access to health care. In my opinion, they pay taxes in the state just like the rest of us in this room. And in fact, in 2018, undocumented residents paid an estimated $375 million in taxes for the federal government, towards the federal government, $242 million in state and local taxes as well. Our current health care policy ignores these contributions of these undocumented Marylanders to our economy and also our society. By opening up the exchange to this population, we would be bringing down Maryland's overall uninsured rate and individual premium costs. The bill is a major step forward in creating a more just and equitable health system here in Maryland by expanding care to those who remain undocumented by doing so through the Health Benefits Exchange. And with that, I'd like to thank my sponsor panelists who are here to testify. I see that Mr. George Escobar from CASA has joined us. We also have Ms. Taylor from Kaiser Permanente and Ms. Erin Dorian from the Maryland Hospital Association. So I'd like to thank the committee and urge a consideration.
Don't go anywhere yet, because I do have a question.
Yeah,
I see
I will
that
be here.
Senator Augustine does, so we'll start with Senator Augustine.
Thank you, Madam Chair. This is a very important bill, good bill. I appreciate it. The fiscal note, though, is significant, the way that it is presented. The cost of like $100 million. And you talked about like EMTALA and some of those other costs, but I've been trying to find in the testimony where we could quantify that. You know what I'm saying? To be able to really make this case.
Sure. So thank you for that question, Senator Augustine. I think there are a few things that are important to keep in mind. I think this bill gives a lot of flexibility to the exchange to be able to implement this type of program. And in fact, the report that they generated as a result of the JCR provided a few different scenarios that the exchange should go through to be able to implement this program. And what you see in that fiscal note is actually potentially the most expensive. And they could certainly scale that down to, depending on how much funding is received from the federal government as part of the 1332 waiver, which we're not entirely sure, right? This would be new. We would be the first state in the country going through this type of 1332 waiver to be able to bring in these federal dollars. And then we can scale the program to make that work with the amount of funding that we have. There are different things that you can do. I think there's some scenarios that Ms. Eberly and her team at the Health Benefit Exchange looked at. The fiscal note reflects the full population that could be covered. But you could do things like setting different federal poverty limits for that, and that would also set certain thresholds by which people would qualify. Other states have also looked at potentially setting age limits, so you could make it so that it's everyone under 18 or everyone between 18 to 34. You could have discretion to be able to do that. The bill allows for that discretion and allows the Health Benefit Exchange to be able to look at those scenarios as well. What is difficult to quantify, as you point out, is that those who are undocumented, who are seeking care in our emergency rooms, that's probably the most costly form of care that people can undergo. And it's also the type of care that has the least amount of continuity, right? So it's just purely episodic. You're going there for an emergency, and everyone that walks into emergency room, documented, undocumented, whoever, gets emergency care. And so it is hard to gauge how much cost savings there would be. And it's referenced in the fiscal note towards the end that potentially there are additional cost savings that are not factored into the table that you see up front because you would have more people be able to get primary care, access to good primary care, continuity of care would be improved, and that would drive the overall cost downward, as well as for those who are are otherwise in the individual market or going through the Health Benefit Exchange, because you're able to reduce the amount of uninsured people overall, that means less people are getting uncompensated care through our emergency departments and emergency rooms, thus overall reducing the premiums for everyone. And so that's also not factored into the fiscal note. So it's hard to gauge, but it's a good question.
Okay, and just for my clarification, Madam Chair, it shows on here, because you were talking about the federal funds, and I know that that was the plan, like the application to get the federal funds. But on the fiscal note, it's talking about state funds. Am I not understanding that in some way?
So to make this work, it's a combination of state and federal funds that would come in.
Okay.
And so the 1332 waiver, if we were authorized or approved for it, would bring a certain amount of federal dollars in. The rest of the balance of it would probably have to be made up by state dollars.
Okay, thank you. I really appreciate that.
Are there other questions? All right, well, let's go to the panel. You have any order that you prefer? Is there a lead panelist? Sure. George Escobar?
Sure.
Okay.
Thank you very much for the opportunity, Madam Chair. My name is George Escobar, and on behalf of our over 120,000 Black and Brown members at CASA, I want to urge a favorable report on SB 728 from this committee, as it speaks directly to one of the fundamental priorities our organization and our membership has expressed to us. Now, you all are probably familiar with CASA. We're the foremost immigrant services and advocacy organization in the Mid-Atlantic region. But by far, the place where we have the largest contact with the largest number of members is through our health services. To give you an idea, just over the past year alone, we facilitated access to over 13,000 COVID vaccinations. Over the past year, we have also facilitated access to over 15 other thousand folks have been navigated to some sort of healthcare or social service. Now, why is that? you may ask, right? Apart from all the other services that we provide. It is because fundamentally our membership is primarily undocumented and by definition uninsured and excluded from the formal healthcare sector of this state, right? They're only able to access our safety net that we all know is overburdened and underfunded and only able to address a particular health crisis of the day, but not comprehensive coverage, not preventative coverage in any kind of way. That is not the sign of a healthy healthcare system, right? And we believe that this piece of legislation goes a long way towards creating a much more resilient healthcare system that is better able to withstand the worst parts of a pandemic that disproportionately impacted our communities currently, right? We know that the state must be applauded and has taken great strides in the past few years, right? It has opened and established a healthcare marketplace. It expanded Medicaid and taken great strides and has taken health equity seriously. But still, over 5% of our population has not reaped any of those benefits because of their immigration status. So we believe through this legislation, we are talking about creating a healthcare exchange, creating access to every single Marylander, just as the ACA envisioned, right? Access to health plans that can be purchased by individuals, and then creating the infrastructure for a subsidy program, right? We believe this is a key fundamental step that will take us in the direction of health equity and access for all Marylanders. Now, one thing, of course, and it has already been mentioned, the fiscal note has recently come out. We may have disagreements on how they came up with that particular amount, but what we want to urge you is to look at the entire bill in of itself. We really want to discourage this bill from being from not receiving a favorable report just because of the sticker shock that comes with it. We believe
You have to wrap up your way over.
Right. And just to sum up, the important piece of this is opening up the marketplace so that all Marylanders, regardless of immigration status, have the ability to even access the healthcare, the Maryland Healthcare Exchange, which right now, because of their status, aren't even able to shop for a qualified health plan. So this bill would address that and would begin to build a subsidy, and we encourage and we want to work with this committee in the future to make that subsidy a reality and make affordable coverage a reality. But for now, we really urge, first, let's open up the marketplace to allow every Marylander an opportunity to purchase affordable health care. Thank you so much. We urge a favorable report.
Okay, Allison Taylor.
Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Kaiser Permanente provides health care and health coverage to over 450,000 Marylanders, including in the individual market where we have offered health plans since its inception in 2014. My colleagues, Mr. Escobar and Senator Lamb, laid out the health rationale why this is beneficial for the whole state for this, but I wanted to provide a little bit more context from my perspective. This past year, I took a constituent request from one of the members of the General Assembly here for someone who had lost, who their Kaiser Permanente plan had been terminated. And I looked into this, and it was an individual plan that this person had bought through the exchange. And unfortunately, somehow this person's immigration status came into play here, and that was the reason that this person lost their coverage. And so we tried to find a way to keep this person on their Kaiser Permanente plan, but we're not able to because because of the rules here. And so you know, that was heartbreaking for me, and so I'm happy to support an effort that would address a situation like that. Kaiser Permanente serves, as I said, members in Maryland, but also about 12.5 million members across the country. A number of states that we operate in have already done something like this. California is probably the biggest one, but Oregon, Washington, and Colorado, where we also operate, have done this. And KP's been at the table and worked to try to find a solution for this in all of those states, and we continue to stay at the table here to see what can be done about this. So we urge a favorable report. Thank you.
Thank you. And you're next. You have 2 minutes.
Thank you, Madam Chair, members of the committee, and thank you, Senator Lamb, for introducing this important bill. For the record, I'm Erin Dorian, representing the Maryland Hospital Association and our 60-member hospitals and health systems. We are here and happy to be here in support of Senate Bill 728. Hospitals are strong proponents of the state's efforts to expand health care coverage, which is key to the success of Maryland's total cost of care model. Uninsured, as you've heard, uninsured individuals often forego primary and preventative care and end up delaying care, the necessary care, until the situation is an emergency and they end up in our emergency departments. Providing subsidies for residents and opening up the market to Maryland residents who are currently ineligible would close the gap in coverage and improve access to the healthcare system before the emergency department. Ensuring patients can access the right care at the right place in the right time is necessary for improving the health of all Marylanders. And for these reasons, we urge a favorable report on Senate Bill 728.
Okay, thank you to this panel. All right, we'll move now to the following persons. Vinnie DeMarco, Christine Crone, Monica Guerrero Vasquez, and Pam Casemeyer. Well, somebody's missing. Is Laura Atwood here? All right, you may join us. And the mics are movable. You have 2 minutes each.
Madam Chair, members of the committee, thank you very much for this opportunity. I want to thank Senator Lamb for introducing this very important bill. This committee and the Maryland General Assembly has made tremendous progress in reducing the number of uninsured in Maryland by half, fully implementing the Affordable Care Act, and building on it with the reinsurance, youth subsidies, and so many other measures that have come out of this committee and the Health Insurance Coverage Protection Commission. Thank you, Senator Feldman, for your co-chair of that. I believe that it's very important to go from the 6% uninsured we have now to 0%. And though we're fifth best in the nation, we want to be the first. And the most important way to substantially reduce the number of uninsured, as you've heard from the first panel, is by covering undocumented immigrants. We all suffer when so many Marylanders are uninsured and go to the hospital and aren't covered, and our health insurance premiums go up to pay for uncompensated care. And it is a travesty that so many people lack health insurance. Since the laws that you all passed, we've heard story upon story of Marylanders who have benefited, whose lives have been saved or made much better by the health care laws you have passed. Please do that again and expand that coverage to these hundreds of thousands of Marylanders who simply by their undocumented immigrant status are denied these same health care benefits. We strongly urge favorable report on House Bills, Senate Bill here before you that Senator Lamb has put in. The Maryland Health Care for All Coalition is fully behind it, and we urge you to pass it this year. Thank you very much.
Thank you. All right.
Good afternoon.
You may pull that over to you, so yes.
Good afternoon, Madam Chair. Pam Casemeyer apologizes. She's testifying in another committee right now. But my name is Christine Crone, and I'm here on behalf of the Mid-Atlantic the Mid-Atlantic Association of Community Health Centers and the Maryland chapter of the American Academy of Pediatrics in support of Senate Bill 728. This bill would allow Marylanders, regardless of immigration status, to participate in the Maryland Health Benefit Exchange if they otherwise meet eligibility requirements under the Affordable Care Act. As providers who serve the community regardless of payment status, there's clear evidence that this population suffers from a lack of access to healthcare services, which result in higher hospitalization rates and poor health outcomes that not only negatively impact these individuals, but also increases healthcare costs overall in the state. Passage of Senate Bill 728 will not only dramatically increase access to affordable coverage for one of Maryland's most vulnerable populations, but will also lower overall healthcare costs and individual market premiums for all Marylanders. A favorable report is urged.
Thank you.
Hello, Madam Chair and members of the Senate Finance Committee. My name is Laura Atwood. I've lived in Maryland since 1999, and I'm representing Tacoma Park Mobilization, a grassroots advocacy organization with over 2,500 members. We are in support of SB 728. I'm also testifying as a healthcare employee who's so often struck by how many health problems with accompanying anguish and multidimensional costs could be prevented. I'd like to share the story of one man, whom I'll call Mario, who was my home health patient a few years ago. To backtrack, I work as a home health physical therapist with patients who are homebound or unable to tolerate going to an outside PT clinic. I typically make 4 to 6 home visits per day, and this has continued throughout the pandemic. People invite me into their homes and their lives, hoping that I can help them get stronger and healthier. Normally, people without insurance are simply absent from my work life. I rescheduled my current patients for today so that I could be here in person in solidarity with those who cannot be my patients. So to go back to Mario, he was uninsured and had come through my organization's hospitals, so we were able to make a very few unreimbursed visits, and even this is uncommon because of the cost to healthcare organizations. He used to have insurance, but he lost it when he changed jobs. He didn't qualify for Medicaid or ACA subsidies because of his immigration status, and he couldn't afford his cardiac medications, which were $30 a month. So he had a simultaneous heart attack and stroke, couldn't return to his restaurant job, which included heavy lifting, and couldn't pay rent for his room in a family's home. The family, including elementary school children, relied on that income as well, but they didn't want to make him homeless. The man was in his early 50s. How much better would it have been in so many ways to prevent the cascade of devastation from his lack of health insurance? We need to do what we can going forward to prevent others from facing Mario's situation. SB 728 would be an important step. Tacoma Park Mobilization therefore urges a favorable report on SB 728. Thank you for your time.
Thank you. And we'll go now to, are you Marie?
Good afternoon, Madam Chair. My name is Monica Guerrero Vasquez, and I'm here to represent Central Sol in support of SB 728. I'm going to tell you a short story about Brenis. Brenis is a young 34-year-old man from El Salvador. He had an accident at his job, and he was not able to seek for care. He had a lot of pain and couldn't recover from it. He didn't know what it was. He still doesn't know what it was. The main fear for him is not the pain or what it could be, but the bills that he could entail if he has to seek for care or therapy for his injuries. And like Brenis, I see every year hundreds and hundreds of individuals who are scared more of this potential illness that they may have, of the bills of seeking care and really not being able to access any type of care in the city. Central Sol is the Center for Health and Opportunities for Latinos, and we are committed to promote equity in health and opportunities for them in developing several community-centered programs. So we work with the communities to understand what are the main challenges and issues that they may encounter. So we are here to express our support for HB 728. While, as we heard, uninsured rates have decreased, Latinos have the highest uninsured rates of any ethnic or racial group in the state. We also know that the state of Maryland is one of the most diverse states in the country. However, we're not providing the resources that they need. Expanding access to health insurance will provide an opportunity for individuals like Brenis to seek timely care and reduce hospitalization admissions for preventable conditions. This is going to impact our healthcare system overall, reducing the admission for preventable conditions, which is higher among undocumented immigrants. The program will expand state premium assistance and cost-sharing reductions to individuals, including minors, regardless of their immigration status. This bill is an urgent and needed public health intervention to protect the health of one of the most diverse, rich, and fastest-growing communities in our state, and yet one of the most vulnerable. This bill will also ensure that our hospitals are able to handle emergencies by reducing hospital admissions. The state have the power to improve the lives of our communities now and for the future. For these reasons, Central Soul supports this bill and urges a favorable report for SB 728. Thank you.
Thank you. Are there any questions? Okay. Now we're going to Naomi Renato. Is Erica Cabrera here? All right, you have 2 minutes each.
I will be interpreting for them.
Okay.
Okay. Naomi, comienza.
Buenas tardes, senadores. Mi nombre es Naomi Granados. Gracias por la oportunidad de testificar hoy en día. Vivo en el condado de Prince George, soy indocumentada y desafortunadamente soy uno de los miles de indocumentados que no somos elegibles para tener seguro médico. Estoy aquí porque creo que la salud es derecho humano, no un privilegio.
Good afternoon, Senators. My name is Naomi Granado. Thank you for the opportunity to testify today. I live in Prince George's County. I am undocumented, and unfortunately, I and the hundreds of the other immigrants without status are not eligible for health care coverage. I am here today because I believe that health care is a right and not a privilege.
Esta es mi historia. El año pasado, en diciembre, tuve un accidente de carro. Fue muy doloroso, pero estoy agradecida de estar viva. Después de que el accidente fui a ver un doctor y me dijeron que el accidente había dañado mucho mi cuerpo. Sin seguro médico, el costo de recibir de servicio me costaba $13,000. Yo no tengo tanto dinero, no conozco a nadie que tenga tanto dinero antes del accidente. Yo pesaba 155 libras y ahora hoy peso 135, lo que significa que estoy perdiendo mucho peso y necesito ver a un doctor ahora más que nunca.
Here is my story. Last year in December, I got in a car accident. It was so painful, and I'm really grateful to be safe. After the accident, I went to the doctor and realized how much damage the accident had done to my body. Without insurance, the medical costs came up to $13,000. I don't have that money. I don't know anyone who has that kind of money. Before the accident, I weighed 155 pounds. Now I weigh 135, which means that I'm losing a lot of weight. I need to see a doctor now more than ever.
Esta ley me daría la oportunidad de comprar seguro médico accesible. Mi hija tampoco tiene seguro médico. Ningún niño debería quedarse sin la atención médica que necesita.
This bill would allow people like me to be able to buy affordable health care through the marketplace. My daughter doesn't have health insurance either. No child should be left without the care that they need.
Senadores, nuestra comunidad los necesita, mi familia los necesita. Por favor, muevan la ley. Gracias por su tiempo y gracias al senador Lam por su liderazgo.
Senator, our community needs you. My family needs you. Please move this bill forward. Thank you for your time, and thank you, Senator Lam, for your leadership.
Thank you. All right. And then are you Erica?
Yes, she is. I'll be translating for her as well.
Okay.
Okay, Erika. Comienza.
Muy buenas tardes a cada uno de ustedes que está presente aquí en este lugar. Mi nombre es Erika Cabrera, soy miembro de CASA, vengo en Maryland, vivo en Prince George.
Good evening, everyone. Good afternoon. My name is Erika Cabrera. I am a member of CASA. I live in Maryland in Prince George's County.
Vengo aquí porque hace un año tuve derrame cerebral y fui en el hospital.
I am here today because a year ago I had a stroke and I went to the hospital.
Y sí me dieron medicina, pero ya después ya no me dieron tratamiento porque uno no tiene Medicaid. Y me quedé con el dolor de la cabeza y de la vista.
And I did go to the emergency room and they gave me some medicine, some pills, but afterwards they no longer continued to treat me. And to this day, I have problems with headaches and my vision.
Y no me dieron terapia en el hospital. Y tengo miedo y tengo 2 hijos, uno de 8 años y otro de 11 meses. Y tengo miedo de que me vuelva otra vez con él.
I'm scared because I have 2 children, one who's 8 and another one who's 11 months. And I'm really scared because I don't want this to continue. I don't want my health to deteriorate. I'm worried for them.
Okay.
Y que necesitamos que ustedes, senadores, a cada uno de ustedes que nos escuchan, que nos dan Medicaid a todos, no solo a mí. Hay otras familias que sí, igual está con esa situación que tengo. Y hace 6 meses ahorita
Senators, I am here to ask you guys to listen to my story. I am here representing many families who don't have access to care. Please give us access to care.
Okay.
Thank you.
Thank you.
Gracias.
Thanks to both of you, and to the translator.
Thank you, guys.
Okay, I think that's the final testimony on that bill. All right, we're going next to Senate Bill 725, Senator McCray.
I think there was one more.
All right.
There was one more person to testify, Madam Chair, on that last bill.
Then that's. They told me that the other person was ill.
Oh, probably was some misunderstanding. Could she just provide her testimony?
Senator Lamb's office just sent me an email saying she was sick today.
Your office sent us the email saying she was
I
sick.
think that might have been someone else.
All right. Is it okay if I come up?
Yeah, you have 2 minutes. This is a mess. Just the last 2 didn't help.
Good afternoon. Thank you, Chair Kelly and Vice Chair Feldman, for the opportunity to testify today in support of Senate Bill 728. My name is Marie Ezrin, and I'm currently a medical student at the University of Maryland. In a few months, I will be a bilingual physician, hopefully in the state, so while officially I'm only testifying on behalf of myself, unofficially, I'm also testifying on behalf of the future patients that I will be taking care of. I'm here to share with you the brief story of an undocumented patient whom I never got to meet in clinic because he did not have access to affordable health care. Last year, a patient approached me at the end of her visit in clinic to ask about a question about her brother's health. She shared with me symptoms that sounded like obstructive sleep apnea, a condition in which people temporarily stop breathing during their sleep. Without proper diagnosis and treatment, his condition is associated with higher rates of elevated blood pressure, heart attacks, and stroke. Because her brother was undocumented and did not have access to health insurance, he basically had 3 options. Option number 1, pay out of pocket for health care, which is simply not feasible for him, just like for most Marylanders. Option number 2, attempt to get medical care at a charity health organization that accepts undocumented individuals. Having volunteered at these wonderful charity clinics, I know firsthand that patients can be on long waiting lists to access this health care, or they're not able to access the specialty care they need through these organizations. Or option number 3, which was what I've seen and is what happens often, wait for the condition to worsen so that now with a life-threatening medical condition, he cannot be denied care at an emergency room. Not allowing undocumented patients like him to access affordable health care is financially illogical, it's poor public health, and most importantly, inhumane. Today, with this bill, we have the opportunity to improve the health of our state by allowing all qualified Maryland residents the opportunity to purchase affordable health insurance. As a future primary care physician, I respectfully urge a favorable report on Senate Bill 728. Thank you.
Thank you. Are there any questions? Thank you very much.
Thanks.
Okay, now we'll go to Senate Bill 725. And let me call up your panel: Barbara Mercado, J.D. Shepherd II, and Roy Film. Senator, you have the time that you need to lay out the parameters of your bill, and each panel member will have 2 minutes each.
Yes, ma'am, and I'll be very respectful of the committee's time. Madam Chair, members of the committee, for the record, Corey McRae here for Senate Bill 725. Senate Bill 725 is very simple. What it does is it just basically prohibits imposing a copay, coinsurance, or deductibles for physical therapy services greater than copayments, coinsurance, or deductibles for a primary care visit under the same plan or the same contract. High copays, we know, can lead to patients managing pain with low-cost opioids, which can lead to dependency. We all see this across the state of Maryland. You'll hear from a number of panelists today, Madam Chair, that will give evidence and has repeatedly shown that within the past 10 years that early PT decreases opioid exposure and is significantly more cost-effective over the long term for Marylanders. Physical therapy's involvement in patient care improves outcomes and reduces costs and strain to our very own healthcare system. Senate Bill 725 will work to eliminate a significant barrier to continuity to care by limiting the cost of copays for PT services to no greater than that of the primary care services. Just also think that this is one of a good bill just in reference to access, making sure that everybody can have the opportunity to access for this with the cost-efficient measures. Madam Chair, you have a phenomenal folks. You have President Shepherd. You also have Mr. Film from American Physical Therapy Association, and I will not hold the committee hostage anymore, but do ask for some form of a favorable report, if possible, for Senate Bill 725.
Are there any questions for the sponsor? All right, if not, then we'll go in this order. Barbara Mercado, J.D. Shepherd II, and Roy Film.
Hi, Dr. J.D. Shepherd, President of APTA Maryland. Madam Chair, thank you for the opportunity to speak in support of Senate Bill 725. This bipartisan bill is needed because patients see rehabilitation practitioners at a much higher frequency than they do physician specialists. Therefore, we welcome the Chiropractic Association's amendment and thank them for their support. The typical patient sees their physical therapist once or twice a week over the span of 1 to 3 months. With some copays as high as $50 to $75, many insured patients are unable to afford the care they require. You will hear that treating physical therapists with the same rules as a primary care physician will disrupt the healthcare system. But this has not occurred in the 11 other states who enacted similar legislation. Over 90% of PTs are generalists. Unlike physicians, even specialized physical therapists cannot use specialization codes for higher reimbursement. As a result, our patients are paying for a much higher percentage of their care with copays. The fiscal note likely does not account for the cost savings and preventative measures physical therapists can provide. In fact, a study has shown over $2,700 in savings when patients with low back pain receive early physical therapy with the decreased need for surgery, opioid use, and imaging. Other patients benefiting would be the 30-year-old woman who continues to have concussion symptoms months after her car accident. She must choose between paying her student loans and receiving care to return to work. The grandmother who undergoes rotator cuff surgery to care for her grandchildren only to realize she cannot afford the ongoing care needed to allow her to pick her granddaughter up. The father of 3 who suffers a massive stroke, whose wife must decide between her children's college education and her husband's ability to walk and talk. This legislation will rebalance the healthcare equation so that patients do not have to make these difficult choices. Thank you, and I ask for a favorable report.
Thank you. All right, I don't see any lights on. All right, who's going next? Okay, Mr. Roy Film.
Thank you. Madam Chair and members of the committee, I'm Dr. Roy Film, and I'm the Vice President of APTA Maryland. I teach at the University of Maryland School of Medicine and served as the National Task Force Leader for U.S. Army MedCom's National Opioid Crisis Community Summit. I'm here today to describe how high copays are one of the unintended drivers of the opioid crisis. More than 2/3 of people who use illicit opioids today in the United States started with prescription medications, prescription narcotics. not street drugs. Many physicians would rather send people to a physical therapist, but high copays make it almost impossible for patients to follow their doctor's advice. The average course of PT for back pain is about 7 visits, and with a $50 copayment, that's $350. That's my car payment. A $75 to $100 copayment, which exists in the state of Maryland, brings that as high as $700, a Jaguar payment. People cannot afford to do that when they're on a plan that has a $100 copayment. And this is on top of their premium. But a 1-month supply of pills often comes with only a $10 copayment. High copays for PT drive people to opioids. Copayments were created to make sure patients have quote-unquote skin in the game, but frankly, copayments are out of control. And every year, tens of thousands of Americans pay the ultimate price, like my 76-year-old father-in-law, Bernal Rossini, whose wife found him suffocating one night as he died after a grueling 6-year oxycodone addiction after an osteoporotic fracture. Or my 71-year-old aunt, Janet Film, who unexpectedly died of an opioid overdose just months after a back injury. Both were on fixed incomes. Neither was able to go to physical therapy. Insurance companies classify all PTs as specialists, but in reality, in Maryland, fewer than 7% of PTs are board-certified specialists. And while medical specialists can use restricted billing codes to generate more revenue, this is not true for PTs, where specialists are no more expensive than generalists. The number one recommendation from the CDC is that non-drug therapy, like physical therapy, should be used to manage pain. We should not be making it harder for physicians and their patients to follow the science and evidence-based guidelines. Thanks for your time.
Thank you. Barbara Brocato.
Madam Chairman and members of the committee, Barbara Brocato, and here on behalf of APTA Maryland. I want to thank Senator McCray for introducing this bill and thank the committee. I want to say that I had spoken to Senator Hayes about this bill, but I just texted him and found out that he has a new baby son, so anymore.
You don't have but 2 minutes.
Oh, I only have 2 minutes. Oh, I can't do this. Okay, okay. So this bill is about quality of life. This bill is about stopping cost shifting to patients. A patient should not have to pay a $70 copay on a $150 visit, or a $50 copay on an $80 visit. Right now, you hear time after time from the insurance industry, we can't afford this increase in premiums. Rehabilitative services in total, which is physical therapy, occupational therapy, speech and language therapy, other rehabilitative services. The estimates that we found were that that is less than 3% of the premium dollar. When the industry gets up and testifies, they talk about what they think their out-of-pocket costs are to the premium dollar. There's never any contemplation of the total care needed by the patient and the greater costs that occur when a patient cannot fulfill their regime of physical therapy, preventive therapy. So whether it's a surgical patient, accident victim, stroke patient, someone with a chronic disease, physical therapy is really a much better option than opioids or losing your mobility. And I would ask you to look favorably on Senate Bill 725, and when there are questions about the fiscal note, I'll talk to committee staff, talk to the fiscal note writer about what we see as flaws in the note. Not that the writer did it wrong, but the actuary for the state of Maryland that developed the estimate.
Okay,
Thank you.
Since you brought up the fiscal note, you want to tell us anything now about it?
Yes, Madam Chair, what the fiscal note says is that this is a $47 million cost to the state employees' plan. The fiscal note, well, the first, underpinning is that the state employee health insurance plan is not mandated to provide this. They, as a practice, do comply with the state mandates, but this is not legally mandated. Secondly, when we reached out, after seeing the fiscal note, the evening before the hearing in the House, so we only had hours of notification, and we looked at this, and we called the very talented analyst, Jennifer Chassie, who wrote the fiscal note, and said, Jennifer, and she said, we don't understand it. She said, I don't understand it. I called the Department of Budget and Management. They don't understand it. But the actuary for the state plan developed it and explained that our state health care plan is unique. It's unique in that for retirees, that most of the cost in this estimate comes from coverage for retirees, because in the state plan, the Medicare supplement that is usually a separate contract that everyone gets to supplement Medicare is covered by the state plan. So that's the basic information that we were able to glean in the 18 hours we had to look into it.
Okay, are there any other questions? So in other words, there is some prejudice in terms of the narrow focus of the data used to do the fiscal note in this case.
Could I add to when we did the math, it came out with the claims and the amount with the increase of somewhere around $275 per claim. In my practice, we only get reimbursed around $90, so the math there didn't add up to us either.
Okay. Thank you very much.
Thank you.
Thank you.
Now we're going to hear from Carolyn Chinoski, Diana Johnson, and Matthew. Well, let's hear those two, and then we'll hear from Matthew last.
Madam Chair, committee members, thank you for hearing us out today. My name is Diana Johnson, and I'm the Senior Director for Patient Care Services in one of our large academic medical centers here in Baltimore City. However, I'm testifying in my individual capacity today. I'm also a physical therapist with 33 years of experience in the state, practicing in the state of Maryland. And then lastly, I'm a consumer of physical therapy. So I know that it works. I know that it helps to reduce pain, increase function, got me back to work sooner, gets our patients back to work sooner, and gets us back to our regular lives and enjoying our families. So I'm here supporting Senate Bill 725 for two major reasons. One is related to access to care. In the clinic where I work, copays can range between $5 and $75 per visit. And what we have seen is that sometimes patients are rationing their own care, trying to figure out where they spend their healthcare dollar or their dollar in general. You know, do they get food? Do they get their medicines? Do they get their mental health or purchase equipment? They've got to make that dollar stretch a lot longer. We also see patients who are recommended for maybe therapy 3 times a week. The insurance company would pay for therapy 3 times a week. However, the copay prohibits them from getting the therapy at the frequency that they need. So they may get it every other week, or they may get it once a week, which only slows their progress or hinders them from making as many functional gains as they could. We have a mom in our clinic right now whose child receives multiple services because of the complexity of their diagnosis. So they receive physical therapy, occupational therapy, and speech-language pathology services. Each one of those services mandates a separate copay. So this mom is paying $30 for each of those disciplines and is spending $90 every time she comes for care with her child. Another example of that would be maybe an adult who has had a stroke, often needs physical therapy, occupational therapy, and speech-language pathology services. So my concern is that if we don't cap our copays or control our copays and expenditures, that we'll have patients who don't choose physical therapy, which has proven long-term positive benefits for our patients. And then secondly, really quickly, I'm concerned for preservation of the healthcare dollar and from a population health perspective. So my colleagues have already quoted the statistics in terms of the cost savings and the expenses related to. But for patients who don't get early therapy, many of them will develop chronic conditions or comorbidities. Anytime we have somebody who's developing a chronic condition, you're talking about maybe months to years of spending healthcare dollars. As such, it costs the patient more over the long term, it costs the insurance companies more, and it potentially costs the state more. So thank you, and please support Bill 725.
Thank you. And now, are you Diana?
No, I'm Carolyn Chinaski.
You're Carolyn.
Madam Chair,
All right,
members of the committee.
Chinaski.
Thank
All right,
for
you
letting-
have 2 minutes also.
I'm sorry?
You want to pull either of those two mics, pull the mic over next to you.
Thank you.
You have 2 minutes.
Okay. Madam Chair and members of the committee, thank you for letting me speak to you today. My name is Dr. Carolyn Chinaski. I'm the Director for Government Relations for the American Physical Therapy Association of Maryland. I come seeking a favorable report for Senate Bill 725. This bill would increase access to physical therapy. In this state, we have a problem because patients are asked to pay copays and cost-sharing amounts that sometimes exceed what the physical therapist is actually paid for the services they provide. At other times, the patient pays more than 50% of the cost of treatment provided by the physical therapist. And when we talk about copays that run $60 or more per visit, it really becomes quite a burden on the individual and their family. Patients typically see their physical therapist multiple times during an episode of care. But when we've got copays that are so high, it's difficult and sometimes impossible for them to get the health care that they need. And so they make the choice of not getting the physical therapy treatment that their doctor has ordered or recommended. Currently, many health care insurance contracts, the physical therapist is identified as a specialist, and that increases the financial burden to the patient. When you think about yourself, your family, and them needing to see a specialist, a cardiologist, a urologist, they see that person once or twice a year. Maybe if there's a crisis, they might end up seeing them 3 times during an episode of care. In physical therapy, we see our patients 2 to 3 times a week over the course of a month or maybe longer. With copays at $60 a visit, this really becomes prohibitive. The patients either can't afford to see the physical therapist as often as they can, or sometimes they don't even get the care that they need. In states with copay limits, the utilization of physical therapy has increased. And my colleague said earlier that 11 states have already enacted legislation that caps the copay equal to the cost of a visit to the primary care physician.
I hate to butt in, but we're going way over time and we got loads of bills. So if you could wrap up, we'd appreciate it.
I'm sorry, ma'am, I didn't hear you.
We were saying you've gone over your 2 minutes, Samuel.
Okay. I'm sorry.
Did you have a final thing you wanted to say?
Yes, I asked for a favorable report for Bill 725.
And thanks to both of you. All right, now we're going to the unfavorable, Matthew Celentano.
Good afternoon again, Madam Chair. Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland in opposition to Senate Bill 725. We are opposed first and foremost because physical therapists are specialists. treating a specialist like a primary care physician is inappropriate, and it sort of undermines the reimbursement and cost-sharing structure and design to encourage primary care visits for preventive care and healthcare outcomes associated with primary care visits. Because we know that primary care and catching things early is better for outcomes and ultimately saving the healthcare system money, carriers have designed coverage, along with the ACA mandates in this space, to encourage forward thinking. Well visits are $0 copay. Sick visits are generally very low. Primary care is designed to be baked into your premium. It's a part of the insurance structure to make sure that we can cover all catastrophic type situations. Having physical therapists be lumped into this approach is inappropriate. The cost sharing is generally the same as any other specialist and should be treated like everyone else. Physical therapy is also not like a primary care physician where you have a well visit once a year. It is ongoing, like you have heard from the previous panelists. And therefore, it requires a different level of reimbursement. Same as an oncologist. Once again, linking physical therapy to a primary care appointment is inappropriate. If we start cherry-picking specialists that want to reduce cost sharing for their beneficiaries, it has the potential to sort of bring the entire financial structure of primary care down. That would unfortunately have really negative impact on premiums. I do want to mention the fiscal note. It is alarming. I am not sure how it would translate from the state health program to the commercial market. But it is of concern enough that this is a prime example of where we could use the Maryland Healthcare Commission's guidance on how the impact to the commercial market would be appropriate. Lastly, I would like to mention that this is exactly the kind of reason why I think all of you know, and your expertise on these kinds of issues, why we need to get away as much as possible from a fee-for-service model. It makes much more sense, especially with the kind of examples given, to get towards value-based care, value-based design, where we could incentivize physicians to try to get to a holistic place where the improvement is measured and not by visit to visit to visit. I know you have a bill in front of this committee next week that would help tremendously in this space, and we hope that we continue to try to get away from fee-for-service to value-based care designs, which will improve quality and save us all money. So with that, I respectfully ask for an unfavorable report on Senate Bill 725.
Are there any questions? All right, thank you very much.
Thank you.
Okay, that ends the testimony on Senate Bill 725. We're going next to Senate Bill 661, Senator Benson. And let me bring up your panel. Dr. Nicole Brandt, Dr. Magli Rodriguez D. Bittner, and Elia Horton. Now, Senator, you take the time you need to lay out the parameters of your bill, and each of the panelists, you have 2 minutes each, okay? And those mics are movable when you get ready.
Good afternoon, Chair Kelly and members of the Finance Committee. I'm here to present Senate Bill 661, Reimbursement of Pharmacists for Services Rendered. This bill is for the financial well-being of pharmacists in the state of Maryland. This bill is critical in providing pharmacists with financial reimbursement for medical services that would otherwise not happen without this legislation. Maryland pharmacists have committed themselves to practices, services, informational packet production, and administration of services that have advanced the health of Maryland citizens. Nonetheless, for some practices and administration of services that are suitable under the current pharmacist's extent of training in Maryland, and for which insurance companies would repay other medical care suppliers, pharmacists are right now not compensated by insurance. Pharmacists are one of the most available medical services suppliers for Maryland patients, with most Maryland inhabitants living within 5 miles of a pharmacy. Due to the COVID-19 pandemic, pharmacists have been vital to providing services for the general well-being of Marylanders, including, yet not restricted to, directing the administration of vaccinations, overseeing COVID-19 treatments, telehealth, and COVID-19 testing, regardless of the significant job pharmacists play in the medical care framework. Maryland comes up short on the component to appropriately repay them for large numbers of the essential services they give to the patients. This bill's purposes is to change the definition of health care supplier to include pharmacists. The definition change will allow specific guarantors, philanthropic administration plans, and insurance companies to give repayment to specific medical services given by pharmacists at a similar rate as similar services provided by a physician and physician assistant. This bill will assist with guaranteeing pharmacists are repaid for services they render to patients. The absence of repayment is perhaps the biggest obstacle to additional extension of clinical health contributions in pharmacies and clinics. Inability to repay pharmacists, similarly to other progress practice suppliers, will fuel medical care supplier deficiencies and disproportionately sway patients who are already underserved. Therefore, I would respectfully urge the committee to issue a favorable report for Senate Bill 661.
Thank you. Are there any questions? Okay.
And I want to thank these wonderful doctors who are here today to give testimony. I really want you all to know that I profoundly and deeply appreciate your coming here today. Thank you so much.
Okay, thank you. All right, you have 2 minutes each, and the mics are movable. Okay, thank you.
Good afternoon. My name is Aaliyah Nuri Horton. I am the Executive Director of the Maryland Pharmacists Association. We are the largest association for pharmacists, pharmacy technicians, and student pharmacists in Maryland. And I would like to thank Senator Benson for sponsoring this bill, as well as Senator Beidel for co-sponsoring it. We appreciate that. I do have written testimony that was submitted for the record. This testimony is also represented for the Maryland Pharmacy Coalition, which includes all of the major pharmacy professional associations in the state, as well as the chain drugstores as well. At the basis, this bill is for 2 reasons. One, to recognize pharmacists as healthcare providers. We are not in the statute as healthcare providers, if you can believe that. And 2, payment for pharmacist-administered patient care services. As you know, you're very well aware of the challenges pharmacies have with reimbursement with PBMs, and you're going to hear a lot about that in the next couple of weeks. But with these low reimbursements, this is an opportunity for pharmacists and pharmacies to be reimbursed for the work that they can do. And this is work that would utilize the full scope of their education, training, and licensing. And so this would allow not only pharmacists to close treatment gaps, which a number of the other panelists are going to talk about, but also financial gaps that are putting our pharmacies in jeopardy. And so that's when we're talking about the different practice settings where pharmacists are and can provide these services. They're in community pharmacies, hospital health systems, substance abuse treatment, medical practices, as well as in community health clinics and more. And so this will really allow pharmacists to, in these practice settings, to leverage the resources that they have available while also improving patient care and reducing costs. And if you look at the testimony, there are references for pharmacists provided patient care services
providing a return on investment of 25 to 1, and as low as 4 to 1. And even a low 4 to 1 is pretty high when you look at an ROI, an investment. So that's the basic premise of the bill, and again, the other folks will talk about the details in their practice settings, but I do want to mention that this bill was intended to be co-filed with House Bill 1219, and so with my testimony, I provided amendments to this bill that would realign them so that the text is the same. I also understand that MedChi has an amendment to this bill, which we are amenable to. This bill is not about any scope of practice changes, and so their request is to really tag the references to working within scope, specifically to health occupations and the pharmacist scope, which is Chapter 12. We have a broad level of support. The fiscal note is minimal, and it is beneficial to small businesses, particularly community pharmacies. And that concludes my testimony, and I urge a favorable report. Thank you.
Thank you. All right. Which of you would like to go next?
Yeah, we'll go next. Madam Chair and honorable members of the committee, my name is Magali Rodriguez de Bittner. I'm an Associate Dean and Executive Director of the Center for Innovative Pharmacy Solutions at the University of Maryland School of Pharmacy. I'm also a pharmacist that have practiced in Maryland for 39 years. I have provided care at the Baltimore VA Medical Center, primary care physician practice, and community pharmacist, and I have directly seen the impact that pharmacist patient care services have on patients' lives and physician practices. I have also witnessed the struggles that we have had for many years to expand these services and make them a routine and sustainable services for all patients in Maryland. The lack of recognition of pharmacists as healthcare providers and lack of reimbursement for these clinical services by Medicaid and healthcare plans are major impediments to sustainability and access to these services. Our center, in partnership with many stakeholders, have developed and implemented pharmacist programs for the care of patients with chronic diseases. These programs have improved patients' health and well-being while reducing unnecessary healthcare costs. We have seen the return of investments that Aliyah was talking about. For every $1 that employers invest in pharmacy services, they get $4 back. There's decrease in readmissions of 66% with savings that we saw in a month for $560,000 by reducing unnecessary visits back to the hospital and the emergency room. But in spite of all of this evidence that we have provided, many of these programs could not be sustained or expanded due to the lack of reimbursement by the health plans and Medicaid. Currently, we're partnering with the Maryland Primary Care Program. There are over 400 primary care physicians and about 38 practices across Maryland where pharmacies are being embedded or integrated within these practices. But we're struggling to make them sustainable once that program finalizes. The president of the Calvert Medicine Group, who we work with, said, our patients need pharmacy services. This is the best programs that we have added to our practicing year, and we must find a way to reform healthcare payments for these services to continue. This is particularly true with the shortage in primary care providers, needs in the rural community, and the aging of our population. Pharmacists are trained, willing, and able to contribute to the clinical care of our patients in collaboration with physicians and other healthcare providers. We have the evidence that this work reduces costs, improves lives, and we must facilitate that this becomes a common service for every citizen of Maryland by passing and approving Senate Bill 661. Thank you for your time.
Thank you. All right, and so I guess we're going next to Aliyah Horton.
That was me.
You were
It would
Horton.
be Dr. Brandt.
Okay, Dr. Brandt. Okay.
Well,
You have 2 minutes.
I have 2 minutes, so I will speak really quickly. First and foremost, I want to thank Senator Benson and this committee for your time and attention during this testimony. I am sharing my testimony on behalf of the practice setting I work, so it's actually a joint statement that will be submitted written as well. So I've been a practicing pharmacist for over 25 years, and like Dr. Magali Rodriguez de Bittner, I have practiced throughout nursing homes, assisted living facilities, senior centers, senior high-rise buildings, and I currently am embedded in an integrated practice setting at Good Samaritan Hospital called the Center for Successful Aging. Our doctor could not be here today because of the changes of time, but his opinion is also expressed in this letter. I've been working with them over the last 5 years after leaving a VA-based practice, really to set up sustainable services in the community where our older adults want to live and age in place. Medications I've seen throughout my career have impacted many older adults' quality of life and function in a negative way. They can help, but they can also harm. And I think too often than not, our older adults are navigating very complex healthcare systems. What insurance to choose, what medication to choose, and oftentimes what medication they can afford. Pharmacists are at the forefront of helping them navigate those systems. We've helped them to access medications through patient assistance programs. But most importantly, when I've asked our doctors that I work with 3 different doctors in our practice, 3 nurse practitioners, 2 physical therapists, and social workers. They all say, you're such a value to this team, we need more of you to help our patients navigate this complex system. But to Magali's point, we're not getting paid for these services. And so one of the quotes that he said as I was writing up this bill and this joint statement together, we can improve our practice, not only improving the quality of care, but also productivity. We have to be mindful that we have a workforce that's burning out rapidly, especially in the practice settings I work, such as nursing homes. And we need to support each other, and pharmacists can help support the other providers' care in terms of meeting the needs of older adults. So again, these bills that are being proposed, the Senate Bill 661, reimbursement of pharmacists for services rendered, again, will help improve the quality of care, the quality of life of older adults I serve, as well as the cost of care. We need to be mindful of that, especially for older adults who are making difficult choices. And our effort is to touch as many older adults as we can with the best possible services. And as noted, having a pharmacist on the team gives a great advantage to achieve such missions and goals. So again, this is on behalf of myself, Dr. Nicole Brandt. Not only am I a pharmacist, I actually direct an aging center at the University of Maryland. And this has been a mission of our center through education and advocacy such as today to really advance the care of older adults in our state and beyond. So
Okay.
thank you for your time and attention.
I want to be sure, I think earlier I heard one of you say that you are not now in the code recognized as a healthcare practitioner.
That's me. I can clarify that statement. Under the listing of healthcare providers in the code, pharmacists are not there. However, we are
Would
listed.
this be under health occupations?
Under health occupations, pharmacists are not specifically in that main list, are not listed. They are listed in various points in the statute for specific care services. And so it's just, we're trying to level the playing field and just
So
say
then-
pharmacists are healthcare providers and we can continue the business.
So one of your goals is to be in the list where
Yes.
you belong. under
Yes.
health
Correct.
occupations. Okay.
Yes. And that helps
then
with.
when you say also that you want to be properly remunerated for the treatments that you give and that there are financial gaps, that's the other part of what you're trying to. Okay, thank you.
And
All right,
could I
thank you
make
very much.
one clarification about the payment piece? That it is important just for clarity.
Well, we do have some other people about to testify that I'm going to
Okay.
call on. Okay,
Thank you.
all right. Kelly Locklear, Hoyan Chuan, both, okay. And then I'm going to call up the 2 who have amendments, favorable with amendments, George Tolley and Josh Howe. If they're here, okay.
Good afternoon, honorable members of the Senate Finance Committee. For the record, Kaylee Locklear here on behalf of the Maryland Association of Chain Drug Stores. So on behalf of our almost 1,000 chain pharmacies and nearly 3,400 pharmacists operating and providing patient care here in Maryland, the Maryland Association of Chain Drug Stores is proud to support this bill. Senator Benson, thank you for filing this piece of legislation. The legislation would merely require reimbursement of patient care services provided by pharmacists. Improving patient access to care requires reimbursement for services provided by clinicians in Maryland, including pharmacists at a level equivalent to other providers. Failure to do so will exacerbate healthcare provider shortages and disproportionately impact patients who are already underserved. So I'd like to echo the previous comments by the previous panel and urge a favorable report. Thank you.
Okay, who'd like to go next? Just state your name and go ahead, and the mics are movable.
Good afternoon, Madam Chairman, and all committee members. Thank you first to Senator Benson, Senator Biddle, and Senator Smith for sponsoring this bill. I also want to send a greeting to my new Senator Kramer. I recently moved from Gaithersburg to Durwood, from Senator Kagan to your district, and had to meet Monica. Yes. So thank you for being here today. You heard my colleague said already from Maryland Pharmacy Coalition. My name is Hoi An Trong. Hoi An, a lot of vowel in there. Hoi is like chip ahoy cookie. My patient will call me Hawaiian, hotel, all thing. If you like chip ahoy cookie or not, just call me chip ahoy cookie, it's fine. That's what patient call me. I'm here to tell patient's story because I think that, my colleague have provided data, the statistics for you already. My day job, I'm a professor at University of Maryland Eastern Shore School of Pharmacy and Health Profession. I also do work and serve on the governor-appointed Advisory Committee for Minority Health, in which I do work, splitting my time with Maryland Department of Health, Office of Minority Health and Health Disparities also. Prior to that, I practiced in underserved clinic in Montgomery County Primary Care Coalition over 5 years, in which we collected data and published the article that's cited in the submitted written. You will see they show the return on investment 1 to 5 to 1 to 25 when pharmacists are involved. We submitted publication because we feel that it's important for documentation. I'm a public health pharmacist for over 17 years, where I volunteer at Maryland Response Medical Reserve Corps, as well as FEMA Vaccine Clinic during the COVID-19 pandemic. One of the things I consistently see and hear stories from patients, especially, like I said, I'm on the Eastern Shore also, teaching over there, is that access. This bill is about access. There's shortage of physicians, and pharmacists are willing to step in. If we pause and think during the pandemic, when everything closed, pharmacists remain open. And I personally experienced that because when I volunteered at clinic and provided vaccination, and in fact, to the point, bringing COVID home to my own wife and 2 daughters also, because when I volunteer at a clinic, but that is okay because that's what we are set out to do, to provide the access for the patient. So when physicians are closed, and I personally experienced 5 family members hospitalized during the pandemic, and they have follow-up visit, they all said that they cannot get in to see the physician because of access issue, and the pharmacists are ready, willing, and able to see the patient. So if I invite you, when you visit provider office, you often see the statement, payment is expected for service render. I don't think if you walk into a pharmacy, a pharmacist will turn you away from, lack of better word, free consultation. They will never charge you. They have not charged you. So this will put us on an equal playing field because pharmacists are always ready, willing, and able to help without first asking for money or for compensation. Here we're asking for it to be provider status, so we're able to build a third party to be able to be reimbursed for the service we provide, so we can continue to sustain the service for patients as we continue to remain open during the pandemic and beyond. So thank you for your consideration and support of this bill. Thank you.
Thank you. All right, and who's next? Remember, each person has 2 minutes.
Good afternoon, Madam Chair and members of the committee. My name is Josh Howe with Compass Government Relations, here on behalf of the Maryland Association for Justice, respectively asking for a favorable with amendments report on Senate Bill 661. Senate Bill 661 does 2 main things from MAJ's perspective. It makes substantial amendments to the Maryland Insurance Article to require reimbursement for health care services rendered by a pharmacist. The MAJ does not oppose amending the code to require reimbursement for health care services rendered by pharmacists, but there is also the other thing that the bill does is expand definitions in current statute by including pharmacists to them. And in the first part of the bill, the definition of healthcare provider within the Maryland Health Care Malpractice Claims Act would also be expanded by inserting the word pharmacist. And this statute grants special tort protections for healthcare providers who historically have had difficulty buying affordable insurance. MAJ believes that amending the bill to strike that expansion of the definition would be appropriate because MAJ does not believe that this is, that definition is necessary, and pharmacists have not been afforded the protections under the Healthcare Malpractice Claims Act, and have never enjoyed it, and because their insurance has always been affordable. With that, I can take any questions.
Okay, any questions? Okay, and then let's see, is George Talley the last
Yes,
person?
Madam Chairman, thank you very much. Thank members of the committee. My name is George Tolley. I'm a practicing attorney in Baltimore County. I live here in Anne Arundel County, and I'm affiliated with the Maryland Association for Justice. And just to echo Mr. Howe's point, you've heard testimony from the pharmacists and the proponents of the bill that what the bill does is it enables pharmacists to be properly and appropriately reimbursed for the services that they render. And that's what the amendments to the Health General article and the Insurance article do. But there is another amendment in this bill, page 2, lines 15 to 25, to the Courts and Judicial Proceedings article. The Courts and Judicial Proceedings article provisions have nothing to do with reimbursing physicians or pharmacists appropriately for the services that they render. That provision has to do with special tort protections and treating healthcare providers as identified in that statute differently for tort purposes. There are different caps, different procedures, different pre-suit requirements. Pharmacists have not been included in that statute. They have never been included in that statute, and efforts to add them have been rejected by your colleagues downstairs and across the street. And most recently, and in our written materials, I cite to a bill in 2014, House Bill 395, which would have greatly expanded the definition of healthcare provider in the Courts and Judicial Proceedings Code to include all kinds of people like acupuncturists and others who don't need special tort protection because it's for doctors. For physicians who back in the 70s and in the 80s and then again in the early 2000s saw their professional medical liability insurance policies increase in price very dramatically. That didn't happen for pharmacists, and pharmacists didn't come here to the legislature to demand special tort protections to deal with a malpractice crisis. Frankly, there are very, very few, and this is a credit to the pharmacists, very, very few cases that are ever brought, and when they are, they're not the kind of cases that require substantial compensation. So they don't need the protection in that, and you know, it's almost like it was let's find everywhere in the code in the entire red volumes where healthcare provider is defined and add pharmacist. That they went one step too far by going to the Healthcare Malpractice Claims Act and adding pharmacist. Doing that will not help pharmacists get paid. It won't help pharmacists get reimbursed for the services they provide, but it will take away the rights of anyone who suffers an injury because of something that happens at a Walgreens or a CVS or some pharmacy malpractice. Their rights to get full and fair compensation will be impaired, but CVS, Walgreens, and the pharmacists have not had and have not shown and have not demonstrated and didn't testify today that they're having any difficulty accessing insurance to cover their professional malpractice liabilities. So we ask that this bill be limited to what you've been told it's supposed to do. Merely, to quote what you were just told, merely to make it possible for pharmacists to get reimbursed for the services they render, just like a doctor, and not to greatly expand tort protections to a class of healthcare providers. They are healthcare providers, but they're not healthcare providers under the, any more than, for example, acupuncturists or occupational therapists. There are people who unquestionably provide a form of healthcare who are not included in the Healthcare Malpractice Claims Act. And that's been true, and we want to be sure that those distinctions remain because expanding tort protections for no reason at all doesn't make sense and would be a problem.
All right. Now,
Thank you.
Let me be clear. From what I think I've heard, you got two different scopes of practice in terms of what the various people testifying in favor of the bill say they want. Everybody has agreed, I think, that you should be in the two sections of the code, or at least where they list health occupations. And that right now, the pharmacists aren't listed for some reason. They've been omitted from the health occupations.
Yeah, it's the health general article
Okay.
and the insurance article.
Okay. And then in the insurance article, if I'm understanding you, you're saying the pharmacist wouldn't need as much protection there.
So we have nothing to say about what's on page 3 of the bill, which is where the insurance article part of the bill
But then, in
is.
addition, you mentioned the courts and judicial proceedings article.
That's page 2, line 15 to 25.
Okay, and apparently they are listed there in the bill, but should not be according to you?
Yes, ma'am.
Okay, because you say they don't need help for torts.
That they've not come here saying they want it. Nobody testified they need special tort protections or want special tort protections, but this bill gives that to them by adding pharmacists to that particular section 3-2A-01F1.
Okay.
Yeah, and so they shouldn't be added there, so that part can be just stricken out of the bill. And then the bill can help them get proper and appropriate reimbursement for the services that they render.
Okay.
Because that's what the bill's supposed to
Now,
do.
so that I'm clear, and some of us have been out testifying, and people have been coming and going. You've also said, if I recall, that you're not being compensated for the services that you render. I assume that is when you give medical advice or pharmaceutical advice to the customer who comes in needing to know what might substitute if you don't have what the doctor ordered or whatnot. Is that the case?
Correct, yes.
And, okay. Anything else that we're missing?
If I may provide one more example, smoking cessation. And the reason I want to bring that up is very near and dear to my heart. My father died at the age of 52 due to lung cancer, a smoker. And I know Senator Kramer, you support the fight tobacco before. The pharmacists are fully capable of providing the counseling service and help the patient quit smoking. And that is something that is a behavior change, that the patient have a relationship with the pharmacist. The pharmacist can sit down, counsel the patient, and help the patient quit smoking. Right? And right now, if the pharmacist were to do that, she or he is not being reimbursed.
Well, let me just ask this finally. Is that something that maybe 1/10 or 1% of the time pharmacists would be doing, or is that something that happens pretty regularly?
They can be doing more if they were reimbursed and allowed to be reimbursed to do that, because right now they are willing to help, but they have to take the time reimbursed, and if they cannot be reimbursed, they cannot take the time to do that. So right now pharmacists are doing that, but very limited. So with this reimbursement, that will enable them to do more.
I would also just add really quickly, this is actually the first time that we're hearing this, so I think our groups would like to confer with them on it. Yeah.
Senator Kramer.
Thank you, Madam Chair, and I was just going to point that out, that I think it would be appropriate for us to have a better understanding from the pharmacists why it is they felt it's appropriate to be included in this particular part of the statute, along with, and there is a pretty good laundry list of those who are part of the protections that are provided in the courts and judicial proceedings article. So I think that's something we'll need to hopefully get some feedback on from the pharmacists so they can share with us the relevance for that.
We might ask analysts to contact the pharmacy board. That might be the best way.
I can make a quick statement.
Thank you. Okay, we'd accept anything you want to send in.
Okay.
Okay, thank you.
Thank you.
All right, thanks so very much. Okay. Now we're going to Senate Bill 697, Senator Bidle. And okay, if you want to explain your bill, and then we have two people who are favorable with an amendment, Marta Harding and Chuck Connor, if you come and have a seat. So we'll listen to the.
Madam Chair, thank you.
You have the time you need, and everybody else gets 2 minutes each. Okay.
I think we're going to luck out. We're only going to have one person testifying, one witness. So this is going to be your easiest bill of the day.
Okay.
So, good afternoon, Chair Kelly, Vice Chair Feldman, and members of the committee. Senate Bill, for the record, this is Pam Bidle. Thank you for the opportunity to present Senate Bill 697, Mechanical Repair Contracts, Insurance Reserves. Senate Bill 697 is a technical bill dealing primarily with insurance requirements to sell mechanical repair contracts in the state. You know, when you buy a new car, you can choose to buy the mechanical repair at the time of the purchase of the car. So the contract is an optional product that a car owner can purchase to cover repairs and replacements if there is an operational or structural failure of the car. The sale of mechanical repair contracts and the companies that sell them are registered under the transportation article by the Maryland Insurance Administration, including a requirement that the company register with the MIA and provide proof that it carries a comprehensive liability insurance policy called a CLIP for short, to ensure that claims under the company's contracts in the state are paid as agreed. The bill clarifies that there are two types of comprehensive liability policies that are allowed to be used. Both types protect consumers by making sure their claims are paid as agreed. The second thing this bill would do is allow the insurance policy to be issued by a risk retention group properly registered with the MIA. I've submitted one clarifying sponsor amendment that I am requesting to be made to the bill, and Marta Harding is here to testify and provide additional information about the bill. I urge the committee to report favorably on Senate Bill 697 with the sponsor amendment that I've offered. Thank you.
Thank you.
Good afternoon, Madam Chair, members of the committee. For the record, I'm Marta Harding. I'm testifying today on behalf of the Service Contract Industry Council, SCIC for short. You do have our written testimony, which includes some background information on SCIC, and we do want to express our appreciation to Senator Bidle for introducing the bill. As Senator Bidle explained, in Maryland law, a service contract that covers repairs and replacements when there is an operational or structural failure of a car is called a mechanical repair contract, and under existing law, a company that wants to offer these products in the state has to register with the MIA and has to file its contract form along with evidence that it carries, as Senator Bidle explained, a commercial liability insurance policy, a CLIP, to make sure that if something goes wrong, that customers are made whole for their claims. So what this bill does is basically clarify that there are two types of CLIPs that satisfy the requirement. The first type is a policy where the insurer pays any claim that the obligor, the company that sold the policy, fails to pay in accordance with the contract and Maryland law. The second type is a policy where the insurer pays all claims in all cases. So they just step up from what's called the first dollar and pay the claims. Most states allow both types to be sold. Both types, as Senator Bidle said, protect consumers and make sure that their claims are paid. It's just a question of who steps up in the first instance. Is it the insurer or is it the company? But in both cases, the claims will be paid. We had conversations with the MIA leading up to today that I wanted to just relate to the committee. What they explained to me is that this bill is really clarifying, because what they do now under the existing law is when they get a filing of the contract and the insurance policy, they look at it to make sure that if the claim is not paid within the required period by Maryland law, that there is a direct cut-through, they call it a cut-through, to the insurance company by the consumer. If the claim is paid in the required period, they don't care who's paying it. They don't care if it's the company, they don't care if it's the insurance company, if it's paid, that's great, and things are fine. It's just in the case where that doesn't happen, and it's a rare case, but certainly it could happen, and the Maryland law protects against it, they want to make sure the consumer can go right to the insurance company. None of that is going to change. So what they're doing now will continue. So while the bill is clarifying in nature, it is, the industry would appreciate the clarification in Maryland law, because we do think the the law is a little vague about the type of, but about that both types of policies are allowed. So from that perspective, the industry would really appreciate the clarity so that we know what is required in Maryland to sell these contracts. And for those reasons, we would support the bill with the amendments Senator Beidel offered, and happy to answer any questions.
Thank you. Are there any questions? Okay, seems not. Thanks so very much.
Thank you very much.
Okay. Okay, we're going next to Senate Bill 610, Senator Jennings. Okay, and let's see, you've got Thomas Tomsett and Kelly Locklear. Kelly was here minutes ago.
You call me as well, Madam Chairman.
Okay. What is that?
Yep.
Yeah, are you Thomas Tomsett?
Nope, I'm Jackie Anderson.
He's not as good looking.
No, well, it didn't call you.
Madam Chair, I
yet.
am.
Yeah.
Sorry.
Are you favorable, Jack?
Yes, I am.
All right, well, you can have a seat.
Thank you.
Thank you, Madam Chair. For the record, Senator J.B. Jennings with Senate Bill 610, Commercial Law, Consumer Protection, Online Marketplace Disclosure Requirements, the Informed Consumers Act of 2022. This is a pretty simple bill, and it'll take me a minute to explain it. Retail nowadays is done mostly online in a lot of areas. Amazon, eBay, Etsy, Walmart. You want something, you want a little juice box, you go online and buy it. Where's it coming from? Let's say you go to Amazon. Did you know that roughly 56% of the sales on Amazon are done through third parties? Meaning that it's not Amazon who's bought the product and selling it to you, it's a third party, somebody else. The issue is, what's taking place now is theft is all over the place, where people are going into your brick and mortar stores, stealing stuff, and putting it on these websites. In fact, according to the Department of Homeland Security, over $500 billion was done in fraudulent goods last year. This bill is not attacking these websites. They are fantastic. I have no problem with any of them. In fact, my wife uses Amazon every day. It's just how things get listed. The fact that when you go on there and you go to buy, let's say, this juice box, you know, you have a little restaurant and now you have to sell 100% fruit juice, so you go online to sell it for your kids' menus. Do you know who you're getting it from? Did that person buy this the right way that's selling it to you, or did they walk down Main Street of Annapolis and just take it off the shelf and then go and list it online? Many companies have done it the right way. Amazon, I know, I've talked to a couple people that have seller accounts and what it took them to get open. You just don't fill out the form and you're online. It was a several-day process or several-week process. I'll give you a quick, what the one person told me was, they went online, took their account, turned it over to a seller account. They had to put in their address. Amazon sent them a postcard to ensure that that address was in fact a legit address. It had a code on it. They had to go back to their Amazon account when they got it, put the code in to verify that that was their address. They then had to go online through a video chat to prove who they were. They had to show their photo ID. They had to jump up through all these hoops to prove that they were in fact a legit seller. What this bill is doing is saying, hey, we have no problem with that. They need to keep doing it. But we want them to be able to show the information of who they are. Three simple things. Their identify information, contact information, verified bank information, and their tax ID number, so you can verify who they are, that they are legit, that they are not selling fenced goods. It doesn't take effect until they've done 200 transactions or 5,000 annually. And I said, many have already done this. Now, the industry's going to come up here and they're going to fight it and say, hey, we don't want to do this, let's do it on a federal level. We have an amendment that we're going to offer. I believe council's been working on it. That is the exact federal bill that's out there right now pending in Congress. That should Congress act, this is the same bill. So we're not doing something different than would happen on a federal level. It's a pretty simple bill. All we're trying to do is guarantee that when you buy something online, you're not buying something that was stolen from a brick and mortar store in your district. Madam Chair, that is the bill.
Okay, are there any questions? All right. Okay, let's proceed then with Thomas Tomsett.
Your Honor, Madam Chair, members of the committee, thank you. Thomas Thompson on behalf of the Home Depot in strong support of Senate Bill 610. As Senator Jennings said, this bill requires only 6 pieces of information for the seller to provide. That's their name, which can include their business name. That's their mailing address, which can be a business address or a P.O. box. Their email and phone number, which is vitally important to the customer if they ever want to get in touch with them. And then the tax ID and their bank information, which is important to the seller as well as the transactional site, so you can actually have the physical exchange of money once a sale occurs. Once that occurs, the seller is completely finished. They can go about their business selling their products. It then shifts to the online marketplace. That's the people who allow these sellers to come onto their website to make these transactions, and then they take a rake of those transactions, a percentage of the money sold. So once they have the information, the online marketplace needs to do 2 things. They need to verify it. That's easy to do for technology companies of this ilk, very easy. And if they can't do it, there's third-party providers that can do it. And then under the federal bill, and again, that is a consensus bill, and that's the language we're giving to this committee now because we heard that in the House, they need to, at $20,000 of gross revenues, disclose relevant information to customers. That's the country you're in and your contact information. And that's in case anything goes wrong. And you say, well, why is this all important? And Senator Jennings sort of laid it out, and I just want to expand upon it. There's 2 things going on right now in the brick and mortar retail space versus the online retail space. There's organized retail crime, which you guys have heard about a few times in this committee. It's been heard in the judicial proceedings as well. Those are cases where people, professional shoplifters, these aren't just regular people taking 1 or 2 items off the shelf. These are professional folks taking products en masse and moving them online for sale. No overhead for them, and they simply sell all these goods at a profit. That's dangerous for customers and associates in these stores who have to try to prevent people from taking large volumes of items out of their store. But it protects consumers in a different way, too. There's a health aspect to this that kind of will be touched by Mr. Andrzejak, and I'm sorry, my glasses are steaming up. We're seeing a lot of counterfeit goods, and we're seeing that in the healthcare space, in the cosmetic space, in the toy space, and we're also seeing with that, if you were even to look at the Maryland Department of Environment's lead surveillance, housing used to be the primary source of lead exposure for children in this state. Now we're seeing it in other places, secondary sources they call it. That's your makeups, that's your toys. And so health departments need to be able to act when children are being exposed to toxic substances because there's no regulation on how these things are made. Law enforcement needs to be able to act if they see large quantities of the same product that that have exclusive rights with stores like Home Depot that are now online being sold. They need to be able to act, and having this information and having it available will allow those entities to act. This is not new to us. We've done this in the space with regards to pawn shops. We ask them to verify information when people come in to pawn goods. We ask them to wait 18 days before they even put that product on the shelf. Why? So we can avoid these things. This is not a quantum leap for us to make the next step into online safety with regards to crime and with regards to product quality. And so I ask this committee for a favorable report on SB 610, and we'll answer any questions the committee may have.
Are there any questions? Okay. If not, then let's go on to Jack Andrzejak.
Thank you, Madam Chair and members of the committee. For the record, my name is Jack Andrzejak, and I'm before you today on behalf of GSK Healthcare Products. GSK asked for a favorable report on Senate Bill 610. GSK manufactures and packages 25% of the over-the-counter products sold in the United States. This includes, for example, a number of over-the-counter pain relief products, and that could be important, as I'll get to a little later. I should note that GSK products are sold online through online marketplace platforms by very legitimate sellers. But GSK, has been mentioned, has had its products stolen and counterfeited and then sold, through a variety of different ways. The problem is that we see that these stolen products and the counterfeited products can be either adulterated or made from substances that can be very dangerous to consumers. It's important to be able to trace that if, in fact, that happens. It's our view that if these very successful operators of online marketplace platforms can gather sufficient information to bill their clients, then it's not a stretch or, in our opinion, a great inconvenience to require this information to be collected and made available to the public under the terms of this particular bill. I also note that this bill has a number of exceptions in it that would apply to legitimate high-volume sellers whose identifying information is readily available. They are not the target of Senate Bill 610. This bill is directed at that subset of sellers who are not easily identified. If the products sold on the online platforms do not perform as they're supposed to or cause serious healthcare problems, this bill will provide the information that's needed by consumers to pursue those actors or to pursue some other remedy. For those reasons, we urge a favorable report and would support the amended bill. Thank you very much. I'm happy to answer any questions.
Thank you. I don't see any right now. Kaylee Locklear.
Good afternoon again, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Association in support of this legislation. Organized retail crime and professional theft are significant issues that have surpassed $45 billion nationwide, and the impact on Marylanders is significant as well. And to be clear, and Tommy touched on this is not petty theft that we are talking about. This is coordinated attacks on local businesses where thousands of dollars worth of merchandise is stolen, and then it is resold online or in fencing operations that feed all sorts of illicit crimes. Not only do businesses miss out on the lost revenue and have to pay for increased security and staff costs, consumers are impacted by these thefts in the form of higher prices, and the state misses out on lost sales tax revenue. These professional cases also tie up valuable police and judicial resources, and they must be taken seriously. Our legislative committee met to discuss this bill this year, and we are very hopeful that the concerns Amazon will share with you can be worked through, as they ultimately come down to two things in this bill: seller threshold or volume, and the amount of days third-party seller compliance would need to occur in. That's what this argument is still about. So to address some of what opponents will say, this will not harm small businesses. Providing contact information to consumers is already what every single brick and mortar business does. This bill as well is being amended, and it was mentioned to follow the federal bill. But we have no reason to believe that at the federal level, they will be moving this. In the event that they do, our bill will be perfectly in line with the federal level. Our members believe that this is an easy and common sense solution to helping curb this ever-growing problem by creating third-party verification and transparency to stop these illegal businesses forming online and selling stolen goods. Thank you so much for your time and consideration, and I am glad to answer any questions the committee has.
Are there any questions? Okay. And now we're going to unfavorable William Kress.
Who could be against this bill?
Shocking, shocking.
Okay. Also Kevin Callahan. Gary Plump. Zachary Lilly. And following these speakers, Montana Williams. You have 2 minutes each.
Sure, thank you very much. Good afternoon, Chair Kelly, Vice Chair Feldman, members of the committee. My name is Kevin Callahan. I'm a Senior Manager of Government Relations for eBay. And we are here in opposition to the bill as introduced. I look forward to certainly reviewing the amendments that were mentioned on the last panel. As you know, eBay is not a retailer. We do not buy or sell goods, nor do we compete with our sellers. When you're buying from a seller on eBay, you're 100% transacting with a third-party seller. For over 26 years, eBay has existed to provide an open and vibrant marketplace for sellers globally to transact and to foster economic opportunity. We have substantial concerns with the underlying bill. I think it's the privacy issues, which I know we've discussed. It's the, with members of the committee, I think the concern there is really around the public disclosure of seller information. I know in the federal bill that information has been addressed, how that's provided between a buyer and a seller. It's all post-sale rather than being publicly listed, which is a huge concern for eBay sellers. Another issue, of course, is some of the timelines and some of the documents that are required to be collected under the provisions under the underlying bill. Certainly, we take great care to verify and vet all of our sellers on eBay as they reach thresholds. eBay is a licensed money transmitter here in Maryland and across the country, meaning that we're held to federal and state requirements to verify those sellers under anti-money laundering laws and know your customer requirements so that we know that you are who you say you are. As was mentioned, we are concerned about seeing the federal legislation moved here in state-by-state approach. We've seen over 24 states considering differing versions of this. And as a global company and working with sellers across Maryland and across the country, they deserve having some clarity around one national standard. And in that federal bill, there certainly is a state preemption, which was a very important piece that won eBay's endorsement of that bill. We are working in earnest with, I think, many of the proponents to pass that standard, as we view that as really the best way to address seller verification. When it comes to ensuring that we're providing a safe marketplace, eBay has been an industry leader in working with retailers, law enforcement, brand owners throughout the community. We have over 230 retail partners where in the event that they have evidence of stolen items appearing on the marketplace, they're able to contact us directly, have an open line of communication. We work directly with law enforcement, so as they're building out their cases to pursue bad actors in these more sophisticated, multi-jurisdictional ORC events, that we help support those cases. So if that activity is happening on eBay, we're holding those bad actors accountable. And that's really what this is about, is holding bad actors accountable and not targeting legitimate small businesses throughout Maryland and the country who are trying to make an honest living. So with that, I appreciate the opportunity to speak and happy to answer any questions.
Let me just ask one. You mentioned the fact that this federal legislation is under consideration. It could take another 40 or 50 years at the rate the feds go.
Sure, that's always a concern. Good news is, just last month, the U.S. House of Representatives included the Informed Consumers Act as part of the American Competes Act, which you might be aware of, for the chips, the semiconductor chips was part of that. That bill is now in conference, of course. There are plenty of pathways that we're hopeful to see included in a final package that would include the Informed Consumers Act and address this issue. I do think, since we're hopeful that we can see that national standard, really a state level approach that brings together the right people, such as the retailers and loss prevention professionals, law enforcement, and the online marketplaces, all the right people to coordinate and collaborate. We're seeing great success in that in a number of task forces from Illinois to California, Connecticut to Florida. A number of states have adopted these task force models, and they're actually pursuing the bad actors, like we talked about, the ones who are victimizing many of these stores and helping to sell those items.
Thank you. All right. Let's move on then to Bill Kress.
Thank you, Madam Chair, members of the committee. Bill Kress here today on behalf of eBay. In strong opposition to Senate Bill 610, I appreciate the sponsor's intent. And frankly, the proponent's testimony in support of this bill is a little bit baffling to me, in that all of the information that they think will help fight retail organized crime is already collected by eBay and by Amazon. So when I look at this bill, I see nothing in this bill that will address or impact organized crime. If that's something the committee is concerned about, we have ideas on how you can address that. But the seller's information, the address, the telephone number, the bank account, the tax ID number, That is all collected now. Law enforcement and the prosecutors have the ability to access that information. eBay happens to have a portal for that purpose. This bill, quite frankly, is actually anti-consumer, and it's anti-consumer in this fashion. It pushes communications off of the eBay platform onto communication directly back and forth from the seller. And eBay's model is to offer a 30-day money-back guarantee. And part of that process is for eBay to be able to monitor and see the communications back and forth. This bill would push that communication off the platform. That is not a positive thing. We think that there are plenty of standards in place with respect to eBay that address these issues. If we're really talking about organized crime, I would respectfully say that Walmart, Home Depot, and the big box retailers need to figure out a way to address that at the store. We're here to help them to the extent that we can. We have the information, we work with law enforcement, but this bill does nothing more than have a chilling effect on small business because you're forcing us to list home addresses, telephone numbers, email addresses for small sellers in a community, and frankly, in locations that are not set up to receive customers. And so we see the potential for fraud and abuse and scams for sellers if you would dare move forward with this bill. And for those reasons, I would respectfully request an unfavorable report. Thank you.
Okay, any questions? Okay, then we'll go next to Kevin Callahan.
Oh, that was
you, okay. Ari Plott.
Good afternoon, Madam Chair, Mr. Vice Chair, honorable members of the committee. My name is Ari Plout from Boston Plout Law, here on behalf of Amazon, respectfully in opposition to Senate Bill 610. We have submitted written testimony for the record. We oppose for the reasons stated by my peers. Amazon has created more than 29,000 jobs in Maryland, has invested $9.5 billion in infrastructure and employee compensation since 2010. And there are approximately 31,000 in-state small and medium businesses that use Amazon. We have invested lots of resources into theft prevention and fraud prevention, such as technology to ensure that only authentic goods are sold. We fear that requiring Maryland merchants to provide sensitive information on their online listings will serve as a deterrent. And I understand that there have been amendments to this bill. I have not had a chance to review them. Happy to review them and provide feedback. We still would oppose because we prefer the national approach as opposed to state by state, as Mr. Kress said earlier. So with that, we would ask for an unfavorable report on this bill.
Okay.
Thank you.
Senator Kramer.
Yes, thank you, Madam Chair. And I'm trying to get my arms around the opposition here. The bill sponsor has made it clear that the bill that will be before the committee is the exact same bill that is before Congress at the moment. So I heard some concerns expressed that there are 24 states working on legislation and you don't want to have to deal with 24 different standards. Well, we've heard this will be the federal standard, assuming anything ever happens at the federal level, which, as the chair pointed out, is exceedingly unlikely. But is it lost on you at any point that if 24 states are working on legislation on this very issue, there's a problem? There's a problem when you've got 24 states trying to address what is happening with the online marketplace at the moment. And just last week, I saw a whole news program on this very issue, and they were showing high-end eyeglass stores, and I think they featured maybe Gucci eyewear or whatever it may have been. Just people walking in, smashing the display cases, filling bags with the eyeglasses, And then the investigative reporters were showing right there on Amazon the exact same style frames. Were they the ones stolen? Nobody knows. But we've got a huge problem, and clearly the retail sector believes this bill will help address what is happening. Otherwise, I suspect the retail sector wouldn't be here supporting the sponsor's legislation. So, you know, the notion that somehow this is not going to accomplish anything that benefits the retail sector, I suspect is not the case. And I guess I'm just at a loss as to how you think this is going to harm small business operators by virtue of providing information as exists right now. I mean, the bottom line is, if I've got Kramer's shoes, my customers are going to know exactly who I am and where to find me. It's not a mystery. So I am somewhat at a loss as to the reticence to say, yeah, you know what? We've changed the marketplace, good for the online sellers, but you also have to step up to what comes with that in the way of responsibilities. Is that fair?
Yes, Senator Kramer, I appreciate the questions. I would respectfully disagree. And for these reasons, if you pass this bill, there will be no new information that law enforcement can't already access today. So why are there all these bills across the U.S.? I would respectfully submit to the committee that this is a turf battle between the online platforms and the big box stores. And if they were spending more of their money on security and less on lobbying and public affairs, they would probably have a better result. And I say that respectfully. I understand. We work every day at eBay to provide access to law enforcement. There's an online portal. They can access our records, and in fact, in 2020, they got up to 40,000 records. Now, you have to understand there's 1.6 billion live listings. And so we have a free flow of communication. This bill enforcing us to put sensitive information of a seller on every listing page does not help the seller, it does not help the consumer.
Bill, in all fairness to the retail sector, the brick and mortar retail sector, first of all, your comment about, well, law enforcement has access to information. This is all after the fact. I think what the brick and mortar is looking to be a little more proactive and avail themselves of ensuring up front that these are legitimate sellers who have access through your platforms, okay? Your platforms provide the marketplace for legitimate sales and sales of theft goods. You created the marketplace. Clearly there is a problem. To put it on the brick and mortar side as you need to do more, I think that by virtue of the marketplace being created to facilitate stolen goods, there has to be greater responsibility in the marketplace, the online marketplace, to protect against that.
So respectfully, Senator, I think the online marketplaces are doing everything that they can. I don't think that this bill provides any new information. We are sympathetic to their problems with loss and stolen goods. But this bill does not advance those causes. If you were to be serious about dealing with loss on the retail level, and I would respectfully suggest that you would have law enforcement at the table, you would have prosecutors at the table, perhaps the online platforms. But that's not what this bill does. This bill says to us, take your seller's personal information, sensitive information, and list it on every page.
And what do you
Instead-
refer to as sensitive, Bill? What is that, what is
So
that
it's the
sensitive
telephone number, it's the address of the business, it's the email system. But wait a minute, we have that information. But more importantly, we have a communication platform that protects both the seller and the buyer.
But
And
Bill,
part of
what is sensitive about putting a business address in the name of the seller for the public to have that knowledge?
Because-
Why is that sensitive?
Well, because they're not set up for retail customers. If you're selling Kramer's shoes and somebody thinks that those shoes happen to be stolen, and you have whoever this person feels that you've stolen their shoes and listed it, that they show up at your door, we don't see that as being a good result. This is a matter for law enforcement to take action to work with the retailers. We have the information available for the law enforcement, and we provide it. So this, in all fairness, has been an ongoing issue and a turf battle between the very big box stores and the large platforms, online platforms. And this is just a continuation, frankly, in my opinion.
All right, thank you for sharing that. I'd like to hear the rest of the panel. Thank you, Madam Chair.
Well, we've got some more people. Senator Feldman.
Well, just real quick, Senator Kramer keeps talking about 23 states. So of those 23 states that are bills that have been introduced, how many, if any, have actually passed? And since we're talking about the United States Congress, pending bills, 23.
Yeah, so there's one state in the nation that has passed a bill, and that's the home of Walmart, Arkansas.
Okay. Okay. Thank you, Madam Chair.
Okay. Thank you. Okay. Zachary Lilly.
Yes, ma'am. Chair Kelly, members of the Finance Committee, my name is Zach Lilly, and I'm the Deputy Director of State and Federal Affairs for NetChoice. NetChoice is a trade association dedicated to free enterprise and free expression online. Our members, large and small, some include Etsy, eBay, OfferUp, and Pinterest. We ask that you not favorably report SB 610 as it hurts the competitiveness of Maryland's small businesses and independent sellers, represents a significant privacy concern, and fails to address the underlying causes of organized retail crime. Under the bill, a seller is required to offer their personal data to the online platform that they are using, as we have discussed at this point at length, so I won't belabor the point further. The key distinction being that many of the people who would be forced to give up this personal data are not just traditional retailers, but they're individuals running businesses or side operations out of their home, perhaps making their own goods by hand, et cetera. So Marylanders using the online ecosystem to improve their financial well-being should not be penalized and forced to put their private data at risk. Organized retail crime is a significant problem, one that online platforms take very seriously. This bill seeks to deal with that problem, but succeeds only in vilifying online marketplaces and the Marylanders who depend on them. Instead, the focus must be on the source of organized retail crime and can only be solved through partnership. Now, I do also want to say that I really do appreciate the attempt to shift the language to the federal standard. I think that speaks very well of the sponsor, if I may say so, and yeah, and I will say, so I do really appreciate that. I think the key, from NetChoice's perspective, the key benefit from having that federal standard is even if Maryland adopts the bill that is similar or the same as the federal standard, if that federal standard doesn't currently exist, then that doesn't foreclose the ability for all those other states to pass their own more onerous standards, which then companies may adopt because they don't want to have to simultaneously adopt multiple standards. So you could still import a more onerous standard into Maryland. So I think that's sort of the key sticking point. But again, I do really appreciate that effort.
Thank you. And then finally, Montana Williams.
Madam Chair, before this panel leaves the table, or?
Well, we've got one more person. She's a part of the panel. If one of you would let us hear the last person on this panel. Thank you.
There you go. Awesome, thank you.
Alrighty. Good afternoon, Madam Chair, members of the committee. My name is Montana Williams, and I'm the Director of State and Local Public Policy with the Chamber of Progress. We are a tech industry coalition promoting technology's progressive future. Our organization works to ensure that all Americans benefit from technological leaps. Our corporate partners do include Amazon, Google, and Meta, but our partner companies don't have a vote or veto over our positions. We appreciate your commitment to combating organized crime, but we urge your committee to issue an unfavorable report for SB 610. First, SB 610 would make small online sellers collateral damage in Walmart's battle against Amazon. Brick and mortar marketplace giants are trying to stifle healthy competition and will ultimately hurt Etsy artisans, eBay sellers, and other online micro businesses. According to a recent article in The Atlantic, bills like this will ultimately help Walmart by weakening the competitive advantage of large-scale online shopping platforms. It won't it won't stop sophisticated counterfeiters who will surely adapt to the new rules. Second, more than 15 states have rejected bills similar to this one, to SB 610, prioritizing the needs of online entrepreneurs and consumer choice. Legislators in Republican and Democratic-led states agree this legislation would add additional obstacles that would ultimately hurt small sellers, decrease opportunity, increase red tape, and hinder consumers in search of a deal. As stated earlier, the only state to pass this legislation is Walmart's home state of Arkansas. And finally, the federal version of the INFORM Act has already gained support from retail groups, a coalition including Etsy and eBay, as well as Amazon. Online marketplaces are largely borderless and don't observe state-by-state boundaries. Passing this bill would exacerbate a patchwork of state laws on an issue that is more properly addressed at the federal level. The consensus approach reflected in the federal version of this legislation represents the best model for tackling this issue without harming online sellers, small online sellers specifically. We hope you will heed the perspectives of the legislators who have assessed the consequences of passing state versions of this legislation and give SB 610 an unfavorable report. This bill would take sides for Walmart against Amazon, would hurt small online business owners, and has been rejected in all but one state legislature. We encourage the Maryland legislature to instead support the improved federal compromise version of this legislation that has broader support. Thank you so much. I look forward to answering any questions.
Thank you. Senator Kramer has the question.
Thank you, Madam Chair. And Mr. Plout, I'm going to direct this question to you since you're Amazon. And I think that's, the online retailer that most folks are very familiar with. And I've heard a lot of discussion about this free flow of information. I'm not sure who's part of all the free flow in the information, but let's say Home Depot came to you because they're seeing some kind of proprietary drill package that they sell. It's on the Amazon site. If they just call up and start asking you information, do you just provide that information to them, or is it necessary for them to subpoena Amazon to get the information they're looking for?
Senator Kramer, I appreciate the question respectfully. I actually don't know, I don't have the answer for you.
I suspect the answer is it has to be subpoenaed. Hence, I think the reason the sponsor has brought this bill before us, because there isn't necessarily this free flow of information between the retailers in brick and mortar and the online platforms. But thank you. I appreciate your candor, Madam Chair. Thank you.
Thank you. Senator Jennings.
Thank you. First a comment and then a question. First, this argument you say is between Walmart and Amazon, that's not why I put this bill in. I'm here simply because I know businesses that are having stuff stolen every day. I see it all the time. I hear it all the time. And we're trying to come up with ways to stop it. And I truly believe that making somebody put their information out there, they're going to be less likely to do it. We walk down Main Street, every business has a trader's license. We know who they are. We know who the owner is. You can look at the trader's license and go to the state and say, hey, I have a problem with this store, and report them. When you buy something online at any website, you have that company's information. But when you're buying from one of these platforms, you're buying it from you guys. Nobody knows that it's ABC 123 one-line store that sold it. And again, I don't have a problem with the platforms. I use them all the time. So I just wanted to make that point. But I guess my question is for Walmart, I'm sorry, not Walmart, eBay. When I set my eBay account up years ago, I think all I needed was my name and email address and not much more. What other information do you need when you hit a certain threshold? I understand if I go on eBay to sell, hey, my old iPhone, I'm going to sell that, and maybe, a month later, I'll sell an old drill that I don't need anymore. When do I become a professional seller where you're going to require more information?
Sure, thank you, Senator. So it depends. I mean, it's obviously, I think the threshold is closer to that $5,000 mark. I think it's actually a little bit less than that. But as you know, probably when you signed up for eBay years ago, you probably had a PayPal account as well, where they collected some of that information too. So obviously they had that direct link with us to collect some of that financial, personal information on you that eBay, because of the structuring of the companies, we did not have visibility into some of that information. Now eBay is managing payments, so we are collecting some of that information, more of that information from you. Many of the same pieces of information that are required, under the bill today, admittedly, but certainly not within some of the timelines. eBay is just one of many platforms, as you can imagine, that would be covered, under the bill.
I'm not trying to single you out. I'm just
explaining.
When I set up my eBay account years ago, like I said, all you needed was a couple data points and you were done.
Exactly.
And when do I become a professional seller versus a dad trying to sell a couple things in the house?
Yeah, I think I couldn't throw a specific number on you, yeah.
All right. Thank you, Madam Chair.
Okay, thank you. All right, well, this ends the testimony on this bill. And we're going next to Senate Bill 839. We've got 15 people to testify on this one. Let's call up Senator Rosapep. Okay, and we'll call up Chris Nickerson.
Thank you, Madam Chair. I just want to be sure I got these two bills up, so I want to be sure I'm talking about the right one. So we're talking about 839. This is the voluntary COVID-19 vaccine passport. Okay, great, thank you. To save everybody time here, I just want to frame this, that the passport proposal that is in this bill is also in the other bill, the larger COVID bill. So all this bill is designed to do is to make it easy for people who have been vaccinated, who want to be able to show easily to others that they have been vaccinated, and to help those organizations or institutions that may want to know whether folks are vaccinated to easily access that information. That's the only point of it. This is not mandatory on anybody. It's totally voluntary. The state currently has the MyIR system where you can go in and find your vaccination record, which the state has, which is available now. It's just clunky in terms of being easy to use. What has gone on in other states, what has gone on in other countries, is making it easy. So it comes up on your phone, real easy to do. All the bill does is say, let's make it easy for everybody, and let's make it known to people. One of the other problems with the MyIR is a lot of people just don't even know about it because the health department has not promoted it widely. So all the bill does is said, let's have a easy to use, basically easy to use app showing that you've been vaccinated, and then promote it. That's it, Madam Chair.
Okay, thank you. All right, and Mr. Nickerson is testifying favorable with an amendment, and then we got 13 people unfavorable.
Nice. Good afternoon, Madam Chair, Senate Committee. Thank you, Senator Rosapep. My name is Chris Nickerson, and I'm the CEO of Pinpoint US LLC, a locally owned and operated business here in Baltimore, Maryland. We have been, I'd like to commend Senator Rosapep for his vision and also for pushing the opportunity for folks to have accessible access to their records, their vaccination records, and supporting this effort at the MDH. Our organization started 7.5 years ago by a Maryland school teacher here in Owings Mills. We are now considered the largest multi-state user-consented verification program in the country. Our clients include Coca-Cola, Auto Dealer Verum, Seafarers Union, large events, churches across the country. What's unique about our program, like Senator Rosa Pep said, we're 100% user-consented verification. It's 100% voluntary. We don't and will never look up any records without the individual's user's consent. Close to home, we work with over 10 local health departments in partnership with them, and we have given access to 1.5 million Marylanders access to this digital vaccine verification program. Our platform, our HIPAA-compliant platform, we provide daily wellness screenings, behavioral health screenings, mass communication for behavioral health and opioid addiction. One of the programs that we've fostered at St. Mary's Department of Health with Dr. Brewster was this vaccine check verification program, and that's what we're talking about today. We are here representing the industry and also sharing the lessons learned out there. Senator Rosa Pep is absolutely correct. The platform that my IR system is clunky. It's not very easy to use, and more importantly, it doesn't answer the call for multi-state verifications, right? A lot of our local health departments border Pennsylvania. Pennsylvania does not participate in the smart QR code framework, right? They don't have a digital pass. So our amendments that we list out here is we support these efforts. We just support an opportunity to adopt the international ISO standards for QR codes, right? Because the current smart QR code framework is only accessible in 20 states and very few countries. The other part of the smart QR code framework is that you must have a native app for the user and also the verifier, which we deem as problematic, right? We use a web-based application versus a native app. So having said that, the framework about the Senator Rosa Pep is correct that the framework is clunky, but we support an accessible model for all Marylanders. Thank you for the time. I'm available for any questions.
Okay, let me suggest this. I'm just noticing, Senator, that you also have Senate Bill 40, and you've got exactly the same lineup of people testifying. So why don't, since you're there as a favorable with amendment, why don't you explain your Senate Bill 840, and
Fine.
I'll have your testimony.
Happy to.
We can call up all of the other people, and they can testify on each bill because it's exactly the same list. Okay.
That's terrific, Madam Chair. I really appreciate it. Okay, so 840 is basically the follow-on bill to the law we passed last year on COVID tracing, testing, and vaccinations. It was passed unanimously by the Senate, passed by the House, vetoed by the governor, and then at the special session, we overrode the governor's veto. It's pretty comprehensive legislation dealing with the COVID crisis that Delegate Pena-Melnick, who everyone in this committee knows well, and I sponsored, working with the local health departments, working with a whole variety of stakeholders to get a better system in place last year and this year to manage the COVID crisis. So this bill basically updates last year's bill. Most importantly, it changes the dates extending out into 2023. That's comprehensive, but it's important. Secondly, because treatment was not an issue last year, but treatments are available now, it adds provisions dealing with the availability and promotion of COVID treatments. And it has the voluntary vaccine passport provision that was in the bill we previously heard. Most of the bill is updating the law we already passed, and if we don't pass a bill, the law from last year is in effect. You will hear testimony of two kinds, I think, of concerns about it, and people have been contacting me, and I know they've been contacting you. They fall into two buckets. I won't do justice to them all. But one bucket are people who are very much opposed to a vaccine passport. They're opposed to the previous bill, they're opposed to the vaccine provision in this bill. And I understand that, and I respect their point of view. And that's strictly a philosophical, strategic, policy difference. But then there are a number of groups who are favorable with amendments or opposed, unless we amend it, on specific issues related to pharmacists, related to testing, related to a variety of areas. Delegate Peña-Mellick and I have been collecting all these specific concerns, and we are going to, after this hearing, I wanted to get through the hearing so everybody could get their concerns on the table, and the House hearing has not taken place yet. So after this hearing, Delegate Peña-Mellick and I want to sit down and go through the proposed amendments and come back to you before you vote, if you would, Madam Chair. Let us come back to you with amendments dealing with the concerns that are raised.
Okay, that's fine. And the one person who signed up with amendments is the young man who's right here at the table, and he signed up on both. Everyone else signed up unfavorable. So why don't you go ahead and give us your testimony now with your recommendations on.
He's on 839. There are a few on 840.
Okay.
There are,
Okay.
It's not exactly. the
Okay, there are some additional ones on 840. All right.
Senator Kramer has a question.
All right, Senator Kramer.
Senator, quick question before we have all the folks who are going to come up here in opposition.
I understand.
I'm reading your bill.
Oh, no.
Okay.
As I see from reading it,
Yes, yes.
it says that, and I'm looking first at Senate Bill 839, and then you can verify if there's anything different in Senate Bill 840 that changes this. Basically, the bill would require that the department create a mobile app, and I'm reading from the bill, that enables its voluntary use
Yep.
as a vaccine passport. There's nothing in here mandating that anybody has to put this into their mobile device, is going to be required to have this in their mobile device. This is for those of us who wish to be able to document the fact that we have been vaccinated. Am I correct in that?
You're correct, but I want to add to that, it also doesn't require anybody to be vaccinated.
It does not require anyone to be vaccinated. It does not require anyone to participate
Right.
in any way, shape, or form if it is not their desire to do so.
Amen.
Correct? Now, is there anything in Senate Bill 840 that changes that?
No.
Okay. Thank you, Madam Chair. I hope
Okay.
everyone in the room was listening to the good senator's comments.
Thank you for the
Senator
question.
Hershey.
Thank you very much, Madam Chair. Two questions, one for Mr. Nickerson. Am I to understand, or does your business provide the platform that MyIR would use, or would be a better platform? Is that what your testimony is?
Respectfully, it's a better program.
Okay, so your company benefits if this bill would pass?
No, not at all, actually. We work with the local health departments. Prior to, MyIR is a system, the immunization registry for the state.
Right.
We saw the shortcomings in working with our local health departments, so we built a better system. So we're already working with the local health departments. They provide this free to the residents. So, yes, there is some likeness in that regard, but we're not just locally here. I mean, we can verify in all 60-plus registries throughout the U.S., so that's the difference between us and MyIR.
Right. I think the concern is, although my colleague said that this is all voluntary, if this becomes something that is easily accessible, doesn't this then open up the opportunity for more and more, whether it's businesses or people or events, to then request seeing a vaccination status?
You're absolutely right, Senator. And our concern with the way that the language is that it's limited with the smart QR code framework. So we want accessibility for all Marylanders, but by modeling it after the smart QR code framework, that's limiting. That's the limiting piece of this.
All right, and then for the bill sponsor, thank you.
Yeah.
I think the concern is the old camel nose under the tent. Although it's voluntary now, we end up having this being very accessible. If, right now, again, if I wish to document my vaccination status, I've got a smartphone with me that has a snapshot of the,
I understand.
of the card. And we all have that already. Why, if this is just something to document the status on a voluntary basis, why do we need a program that could enable businesses, events, locations to start asking for this vaccination status?
Well, I would say two things. One is, they can do it now, and in many cases are doing it now, and in fact, this is not related to vaccinations, but it's related to testing. Once a week, we have to show we've been tested, and then we have to fill out that little form every day about our symptoms and everything. So, I mean, the whole world is concerned about the dangers of this epidemic, and therefore has put in place a variety of different tools to how protect us. Some of those tools are not popular. I get that. So there are going to be disagreements on it. My point about this bill is, and I do think we can fix the language to clarify some of these issues, I think it's important, is that making it easier, sort of along the lines of Senator Kramer's point, making it easier for those who have been vaccinated to be able to share that information efficiently, I think is all upside and no downside. You may disagree.
Well, I was just going to say, unless there's a mandate for vaccination status, which many, many people are against, why is there any reason to share your status?
Because if there's not a government mandate, there definitely are situations where organizations or even family members will want to know, have you been vaccinated? Mr. Nixon might address this as well, because he deals with lots of people in this area, but to me, it just simply makes it easier for people to do what they want to do.
Well, I think,
Well,
short.
let me butt in and just ask this.
Sure.
I've got lists, they aren't all together the same, but we've got about 15 people in one case for one of the bills and 16 for the other wanting to testify.
Right.
And what I'd like to do is to just, and almost everybody is unfavorable. But I'd like to get the favorables with amendments on the second bill. We heard on the first bill, the person. And then let's go down and where they're the same, because we still aren't finished for tonight, okay?
I mean, I just think this is a little bit of a slippery slope here. People have the information. If they need it, they want to share it, they're fine to do so. But making something simpler will then, in a sense, make it easier for more people to use, possibly start requesting. And I think that gets us in a position where mandates for vaccinations ends up following. And I know that that is something that many, many people do not want to see happen. So, all right, that's it. Thank you very much.
Okay, thank you. What I'd like to do is the following, to ask now for 840, if Senator Roosevelt, because he's now explained both bills, if the following three people who are favorable with amendment for 840, if you could come to the table, we'd just like to know what you're recommending. That would be Pam Casemeyer, Steve Bress, and Jonathan Cohen.
Thanks.
You have 2 minutes each. Okay. Okay, either of you can start. You've got 2 minutes.
Okay.
Explain why you're favorable with amendment for.
Right, but I was expecting 8:39 first, so please give me a second to catch up.
My apologies to everyone for confusing things this way.
Okay.
Well, you didn't sign up for 839. You Mr. Cohen?
I'm Steve Bress. I signed up for both.
Mr. Brett. Okay, all right.
So,
Okay.
well, 2 minutes, I'll be quick, obviously.
Okay.
My name's Steve Bress, been a Maryland resident for more than 50 years. I urge you to vote no on the bill. It's not in the best interest of Maryland residents as is. But SB 840 is a large bill covering obviously a lot of different topics. Some are reasonable, some not so much. This section that looks into effective treatments is a good idea, as long as all treatments are on the table without political interference. There are many studies on many different types of treatments. There have been since early 2020. Most of them were ignored for reasons. Some were insurance company reasons, some were logistics, but they were ignored. They shouldn't be, nothing should be ignored anymore. The example of that is the hyperbaric versus ventilator treatment. Hyperbaric chambers were shown effective early on as opposed to a ventilator because it didn't inflate the lungs in the way that was harming so many of the patients, and yet it provided more oxygen to them and they were able to recover quicker. There were studies on it. I never heard a thing in mainstream, but the studies exist. Things like that should be on the table. So as long as there's no restrictions as to what treatments are allowed to be looked at, then sure, that's perfectly reasonable to be in. Then we get into a couple of other things. I don't approve of laws where the goal is to use coercive measures to encourage medical decisions, such as vaccinations. There's elements in the bill that says we're going to spend this much money to get the people who are refusers or hesitant, I think is the current phrase. It doesn't try to actually see what the hesitation is, but okay, whatever. But it is specifically to coerce people into doing what you guys want. I understand as legislators sometimes that is a goal. That doesn't mean I have to approve of money being spent to do something that specifically is coercive. Basically, the state of Maryland is not a doctor to an individual. And so nobody in this room really can tell me what is going to be correct for me or my family. They can give recommendations, but they can't tell me that this is safe for you or this is correct for you.
Okay, now you're going over time. We gave everybody 2 minutes each.
Okay.
Okay, thank you. All right.
Do you want me to stay for the next, or would you like me to?
Well, let's see, you signed up on each, okay.
All right.
Go ahead, you want to do the other one?
No.
I'm trying to, when I get people up there, if they
Okay.
sign up for both, we're trying to get them.
Certainly, okay, I'm out of sequence. I'll try to stay on script this time. Sorry, thank you, Madam Chair. I appreciate seeing you again. It's been a few years. And the rest, I appreciate your time. Again, still Steve Bress. Strongly oppose this bill. Basically, the only purpose for a vaccine passport is for discrimination and segregation. By definition, it really can't be about health. The reason is vaccination is not immunization. The efficacy of all of the COVID vaccines was only 90%. It was never 100%. Getting a shot did not mean you were immune. It just meant you got a shot. So when you have a vaccine passport, that's trying to tell everybody you are immune. Well, the only way to find that out is to constantly take tests and see what your immunity level is. So a dramatic number of people who have gotten their shots as coerced or whatever are not actually immune. So trying to pretend that going into a location just because everybody can show a passport means everybody's safe is clearly not true. That has not been true lately. It hasn't been true ever. From my experience, my son had his early childhood vaccines. We ran tests to find out which were effective, and it turned out that he generated no immune response to one of them. Now, those are the allegedly safe and effective vaccines, and yet no immune response. He was not immune. So that shot was not an immunization or anything. It was simply a shot. It didn't. So the fact I could prove he had it meant nothing about whether he was capable of getting the disease for which he had gotten that shot.
Okay.
I assume I'm closing on time.
Yes, you're doing a good job. Thank you.
Okay.
Okay, let me do this. The next person I see signed up on both is Emily Tarcell.
We need Mr. Cohen. I'm Jonathan Cohen.
Oh, Mr. Cohen, we didn't get to you, I'm sorry. Go ahead, Mr. Cohen.
Thank you, Madam Chair. My name is Jonathan Cohen. I'm President and CEO of 2020 Gene Systems. We are a clinical diagnostic testing lab based in Gaithersburg, Maryland. And we have, since the start of the pandemic, conducted close to 250,000 PCR tests for Marylanders. We've got contracts with Montgomery County Department of Health and Human Services and with the Maryland Department of Health to do K through 12 screening. We have been servicing schools, public and private, in Montgomery County, Charles County, and throughout the Eastern Shore, Dorchester County, Wycomico County, St. Mary's County, and several others. I'm here today to respectfully propose an amendment to the bill to provide what I call a clinical lab ready reserve.
Well, now you said, okay, go ahead. Okay, go ahead.
A clinical lab ready reserve. Essentially, the goal, let's remember where we were the first few months of the pandemic, nationally, not just in Maryland, but nationally, we did not have tests. We did not have functional tests. The disease spread, and we were playing catch-up ever since. In contrast, in South Korea and Taiwan, they had tests up and running in a matter of weeks. They were prepared because of lessons learned in 2015 in the MERS epidemic. We do not want to be caught flat-footed and blind again. The ready reserve would be, it's not stockpiling, but taking labs like ours that have invested hundreds of thousands of dollars, $500,000 in equipment. What do we do? Testing's already slowed down considerably. When school is done in June, we're going to have $500,000 of equipment. What do we do with that equipment? A prudent businessman or women would sell it on the open market. We can't keep instruments around and equipment around and people around if they're not being used. The ready reserve would fill that gap between the state we're in now and, God forbid, when there's another, either a variant, another pandemic, et cetera. And essentially, there would be some subsidies for labs to maintain more equipment than they need for routine testing, and there would be a training and drill, essentially tabletop drills periodically, so that we keep our response muscular. And so if and when there is another incident or need, whether it's in a few months or a few years or in a few decades, we are ready. That is the gist of my proposal. I have language at the tail end of my written testimony, which you can see, and I'm happy to answer any questions.
Okay, thank you. Okay, yes.
Because I just asked the sponsor, because I do know Mr. Cohen, you know, his constituent, but I know his company. And what is your take on, do you have a view? Have you talked to him about this idea of a reserve?
I have. And in general, I think it makes sense. And there are other provisions of 840 dealing with the notion of keeping surge capacity. I mean, he's exactly right. It's been true in testing. It's been true in a whole, I mean, that's what we had right at the beginning of the pandemic, where we didn't have protective equipment. We didn't have all the stuff we didn't have. And so I think the thrust of his amendment is very consistent with the thrust of the bill, which is to make sure that we learn the lessons of this pandemic and we're prepared for the next.
Okay, thank you.
Okay. All right, what I'd like to do next is to go to the next person who signed up on each, Emily Tarcell.
So Chairman Kelly and committee members, I'm Emily Tarcell, a mother, therapist, founder of Health Choice Maryland, with hundreds of members across the state who care about informed health choice and medical rights, public and private. And SB 839 is detrimental to both. SB 839 conveys the illusion that those who receive the COVID-19 vaccine are a special class who deserve admission to certain venues which should be denied to the unvaccinated. That false assumption, the false assumption is that the vaccinated present no public health risk and the unvaccinated do. But the CDC itself has said the vaccinated can both get and spread COVID virus, whereas the unvaccinated with natural immunity do not reinfect or spread the virus. So proof of vaccination is meaningless, also because COVID-19 is gone and the vaccine is not very effective against the Omicron variant. The bill is grossly misleading in terms of any individual or public health benefit. In fact, recent data from public health agencies show that one becomes more vulnerable to viral infection as the number of COVID jabs increases. There are also known serious side effects like blood clotting, neurological disorders, heart inflammation. I have family and friends who experience serious adverse events from the still experimental COVID vaccines. So the right to choose to vaccinate it or not must remain a free choice without stigmatization, discrimination, or penalties. And finally, there is significant potential for cyber hacking or misuse of electronic records. Vaccine passports have been withdrawn in other countries for good reason, and we recall a recent security breach in the public health department right here. Vaccine passports are unnecessary, and a total waste of public funds which could be used productively elsewhere.
Thank you very much. We'll go next to Megan Montgomery. You have signed up on both. Is that
Do you
person-
want me to respond also to 840 or just wait?
Oh, well, I was asking that you do for both.
Yes, I signed up for both.
Okay.
So would you like me to go
Go
forward?
ahead, that's what I'm trying to do.
Okay, thank you. Okay, so 840, everything I just said about 839, of course, applies, but other things are in 840 which are very detrimental. So SB 840 piggybacks on an old bill that was created in a pandemic. There's no need to extend emergency measures now to 2024. The pandemic and emergency use authorizations have long expired. Last year, the rationale for letting pharmacists give some childhood vaccines as a temporary measure was based on the contention that visits to pediatricians declined due to the pandemic. But SB 840 wants to expand the authority for pharmacists and their assistants to now order vaccination for children as young as 3, and it does not state a requirement for written informed parental consent. This is wrong, and pediatricians will not have the child's medical records and will not have the time or training to deal with children. Furthermore, childhood vaccination rates in Maryland have been and continue to be among the highest in the nation at 93%. So doctors are meeting the need, and parents, not pharmacists, should call the shots. And just one more comment regarding the last bill is that recent health data clearly shows the vaccinated have a higher rate of Omicron infection than the unvaccinated, and one's vulnerability to infection greatly increases after the second dose. And I've given you documentation about that with charts and graphs. So proof of vaccination is therefore meaningless. And SB 840 is unnecessary, divisive, costly. Please protect citizens' rights and restore some sanity. Thank you.
Thank you. All right, now, you're Megan Montgomery, right?
Yes, ma'am.
And you signed up on both, so give us your testimony for 839 and for 840.
Very good. Thank you. Thank you, Chair and members of the committee. First, I will speak to the issue of the COVID vaccination passport. I'd like to note that there are fact sheets both in the my written comments and in every one of your offices. I am a mother of a minority male child in a Title I school district in Montgomery County. I have seen my community decimated by restrictions and lockdowns. Montgomery County tried to pass a passport, although theirs was a requirement. There was some issues with voluntary passports as well, and it was universally opposed. Businesses, we don't have enough workers to hire the people we actually need to do our jobs. How are we going to hire more people to do vaccine passport checks? DC has rolled back its passport because of the disparate impact that it has that the minority communities and socioeconomically disadvantaged have faced in Montgomery, in the District of Columbia. We ask that this committee votes no on this poorly timed, ill thought out, and discriminatory bill that will hurt the people in Maryland that need our support the most, those that do not have ready access to computers and smartphones and internet. We take it for granted that everybody does, but they do not. For businesses that wish to choose to require a vaccination, there are cards available. We fully support vaccination availability to everyone in the state of Maryland, but this bill is unnecessary.
Thank you. Okay, we'll go next to Alexis Baden Mayer, and you've signed up unfavorable on both bills.
Chairwoman, may I read my pharmacist bill testimony as well?
Oh, I thought you had finished.
That's okay.
That's what I'm asking each person. When you come up, go ahead.
Do both.
Yeah, I'm
Okay.
trying to deal with those who signed up on each.
Thank you. So I'm with Megan Montgomery with the Love Maryland PAC again. And we oppose the continuation of pharmacists being allowed to vaccinate children 3 and up in their pharmacies. In my written testimony, not only is there a fact sheet, but there are 5 or 6 articles about pharmacists who have made life-threatening mistakes with respect to giving children the wrong vaccines, the wrong doses. Pharmacists are not trained to give childhood vaccinations. Many of them do not wish to engage with children. They did not go into pediatrics. There is actual healthcare that we need to have we need to make sure that families who are needing healthcare, full healthcare, heart listening to, eye checks, ear checks, get that, and they're not getting that in a pharmacist's office when they're getting their vaccinations. This is a Trump-era policy that has no place in a progressive state like Maryland. Pharmacists are overwhelmed, they're overburdened, and they're making mistakes. We do not need children getting vaccines in our pharmacies. There's also information in my written testimony about this being a profit push for pharmacies. And we ask you to vote no and protect the most vulnerable children in the state of Maryland. Thank you very much.
Thank you. All right, now we're going to Alexis Baden, Mayor.
Thank you, Madam Chair.
And you're going to testify on both.
Yes, please.
Okay.
My name is Alexis Baden-Mayer. I'm the political director of the Organic Consumers Association. I'm a resident of Maryland. I live in Prince George's County. I have a son who goes to Riverdale Elementary School there. We have a lot of members in Maryland in the thousands. I can get you an exact number in written testimony. I'd like to respond to Senator Rosa Pepp when he says that this just makes it easy to do what people are already doing voluntarily. But I think that what is really happening here was revealed by who showed up to testify in favor of this bill. We see a business that stands to make a $2.6 million contract with this vaccine passport. And this business operates nationally for the largest corporations in this country. So this is, and I guess that reveals why this is in front of the Finance Committee and not the Health Committee. This is really scary to me. I don't think it's a good way to proceed. In my opinion, as a Maryland taxpayer, I don't want to give a single cent to a for-profit business in this context. It doesn't make any sense to me. If they're doing it voluntarily, if this is just to make it easier, well, they can continue to self-fund these voluntary vaccine passports. It does not look like something that taxpayer money should be spent on. It was even more disturbing to me to see Gene Systems show up. You know, they've been making good business, and now they're afraid that they won't have the type of revenue because the pandemic is winding down. They want a ready reserve. You know, we have something like this at the federal level. It's called BARDA, and it's in the Office of the Assistant Secretary for Preparedness and Response. And if you read the Washington Post over the last 2 years, you know how corrupt that agency is. Under Trump, ASPR Robert Kadlec was called out by Richard Bright, who ran BARDA, and he became a whistleblower to show how Kadlec was creating contracts at extreme markups for stockpiled medical countermeasures. So it's not a good idea to create this type of opportunity for graft and corruption here in Maryland.
Now, you're out of time for your first bill. You want to go to the second?
Okay, I'll go to the second. Both bills talk about vaccine passports, and also I'll continue this thought because I think it's very important for you all to consider. You know, we don't print money in Maryland like the federal government does. So graft and corruption hits us, the taxpayers in Maryland, much, much harder than at the federal level. Not that it's okay at the federal level for there to be graft and corruption, but don't create an opportunity for that here in Maryland. Yeah, it's just not the time to be passing new COVID legislation. And I echo what other people have said about the purpose of vaccine passports. It's for irrational discrimination. There have been 244,892 COVID cases, including 9,896 hospitalizations and 1,340 deaths among fully vaccinated and probably boosted Maryland residents. This is a vaccine that is not making enough of a difference to start spending taxpayer money on vaccine passports to try to get vaccine rates up above where they already are. I mean, they're already in supermajority territory. So it's very irrational to go ahead and do this. I've been a victim of vaccine discrimination. I can't go to my local yoga studio. I'm really hoping that that changes. If the state government starts endorsing a vaccine passport, starts spending money on it, contracting businesses to do it, there's just going to be an avalanche, a push towards getting vaccine passports back when most places are stepping away from them. And I think it's time for it to be over. This is just rotten at the core because it's irrational, it's not based on facts, but this could get a lot worse if vaccine passports become connected to financial information and financial institutions.
Okay.
We've already experienced discrimination as an organization. We were kicked off of PayPal because the director of my organization wrote a book in 2021, The Truth About COVID-19, and that was seen as controversial. It's all factual, and then it has opinions that become extremely controversial. So PayPal decided to kill our ability to fundraise. That's not okay, and that's where these vaccine passports go, to discrimination, to reducing our ability to speak freely, and perhaps even being cut off from an ability to make a living, and that's not okay.
Thanks so very much. We're going now to Daniela Di Orazio, and you also have signed up unfavorable on both the bills, so if you could testify. And we really would appreciate it. After a while, it's hard to keep listening, and you guys have been sitting here all this time. I want to get to everybody, and some people have been leaving, and we want to be sure we can hear everyone. Okay.
Thank you, Madam Chair of the committee. My name is Daniela Dorazio. I am a Romanian-American citizen that loves freedom. I strongly oppose SB 839 because this bill reflects discrimination, government control, surveillance, and an attack on one's physical and mental health. Bill sponsor, Senator Rosa Pep, was the United States Ambassador of Romania. I'm surprised that Senator Rosa Pep will bring a bill to this respected body that has the dangers this bill presents. Has he forgotten how easily a population can be controlled by an oppressive government and how difficult it is to bring freedom back to that population? I grew up in communist Romania and was shot at twice during Romania Revolution. So I understand how valuable freedom is. The risk and the problem with this proposal are so numerous, they're overwhelmed. Let's say that COVID-19 vaccine passport is a voluntary thing. Then why is the state involved? Is it because when the state wants it to be required or mandated, it will have the full structure already there and ready to go? As a survivor of communism, I ask you to mandate freedom and not vaccine passport. Our medical information should be private and not used to divide and segregate the population into vaccinated and unvaccinated. My COVID-recovered husband was forced to get vaccinated to keep his job. Hours after vaccination, he spiked 103 fever, crucial migraine, and was referred immediately to an emergency room with stroke symptoms. Next COVID shot can kill him. School children are in constant fear of getting traced and missing 5 to 10 days of school with no academic support, and therefore add additional anxiety and depression that could lead to suicide. Remember, the 2 weeks to flatten the curve turn in 2 years. So the voluntary vaccine passport will turn mandatory. SB 839 is an attack on our freedom and privacy, and I respectfully ask you to oppose it. COVID is no longer a threat, but World War III is knocking on our doors. So please, oppose this bill right now, right here, and make a history as a senator that gives people the freedom of choice over one's own body without external domination or duress in the last days of potential peace on earth.
Okay.
And now I can testify for 840?
Okay.
As I said, COVID-19 is no longer a threat, but we do have a pandemic of mental illness. 8 students in Montgomery County, Maryland, died to suicide overdose, and homicide in the last 2 months. Yet, thankfully, no child died of COVID in 2 years. Please spend our tax dollars on mental health treatments for kids by funding sports, music, arts, more field trips, learning to farm, and counseling. I'm opposed to expanding vaccination privileges for pharmacists to administer all vaccine to 3-year-olds and up. Pharmacists are already too busy to comply with mandatory counseling regulation, much less keep up with interruption of vaccination. Interruption is a primary cause of dispensing error. At no time should a child receive vaccination without parental consent, which is in a bill. COVID is no longer a threat, but as I said, World War III is knocking on our door. So please oppose this bill and redirect our tax dollar for children fun activities because they've been seriously damaged during these COVID-19 restrictions. It's not good. They need help. They need more fun activities. They need more field trips, more music, more sports, farming. They need help. So if there is any money, we need to put those money in kids for their mental health treatments.
Thank you so much.
Thank you.
All right, we're going next to Ario Timothy, and you have signed up also on both of these bills unfavorably. And we appreciate you being here. If you could tell us what your main points are
Yes.
for both of them. Yes.
Okay, thank you for allowing us to be here. On the first bill, SB 0839, the passport, in very simple language, it's a slavery bill. And I want to just put that into a context. I don't like what's happening here. It's very disturbing. The FDA and the CDC have agreed, this is publicized, and all of the manufacturers of these injections have agreed. They don't prevent you from catching the disease. They don't prevent you from spreading it. Many of us know that just on a simplistic level because many people have gotten the injections and still come down and caught it and gotten it. That being the case, they're not vaccinations. And there's no tracking mechanism for who's sick, who can get sick, and who can spread it. So then the question would be is, what is this actually tracking? As a black person in America, when I look at this and look at the history of this country, what I see that it's tracking rebellion. What it's really saying is, who has said, I'm not going to get on board, I don't feel comfortable with these injections, and I'm not going to take these vaccinations or these shots. I'm not going to do that. And that becomes a problem because, like people have said before, it becomes the basis for discrimination where these other organizations, schools, and other facilities in the country can say, you're a Maryland resident. Can you show me that you've taken this process in your phone? No, I haven't. Well, now you're blocked out of society. I mean, this is literally slavery. This is something that we went through in this country, so we can see it very clearly, and I can't understand how this can be something that can be pushed on the citizenship here. And I would say that what it's doing is extending what has already happened in our families. Many people in their own families, if you haven't taken the injection, you can't come around. You can't see your cousins, you can't see your children, you can't see other family members. What they're now saying is we're going to extend this destruction of the socialization of the society from family and give it to the state to now be able to do the same thing. This is very dangerous and it's harmful. Lastly, I will say on this bill, if we look at the vaccine adverse event reporting system, it started in 1990. Over the last 31 years, if you add up every single vaccine and every single shot in this country and look at the deaths that have been reported in that official system, you would have to multiply them by more than 2 over 31 years to come close to how many people have died in that same system and be reported dying in 1 year from 3 shots and injections, which makes this the most dangerous injections in U.S. history, where there's nothing comparable to the level of damage that this is doing to the American citizenship, and people are not talking about this, and the numbers are public for us to see. The last point I would make on that is that, according to reports we're getting now, the U.S. military is experiencing an 1,100% death rate increase in 2021. is a standard rate that is general across the years, but in 2020 run, now there are reports coming out that are saying in the U.S. military, there is an 1,100% increase in the death rate. And the only thing we could think that has happened in 2021 is people have begun to take these injections. So we would say we don't want a system to track these things, that we're concerned now if we should even be doing them in the first place. On the second bill, SB 840.
You went over on the first one, so you don't have quite all of the time.
Yes,
but
ma'am.
Go ahead.
I'll be fast on this one.
Okay.
All right, this one is the Response Act. Two things that I'm concerned with, and I'll try to get right to them. I see this as, one, a genocide bill, and it opens the door for pedophilia. And I'll say why I'm saying that. The first part on the genocide, remdesivir, which is something that the state of Maryland is now pushing to citizens and senior citizens' homes. In 2019, it was demonstrated that this drug, remdesivir, everybody should write this down, remdesivir, when they tried it and tested it for Ebola, it started killing people. It was the most lethal of the drugs that was being tested against Ebola, and they pulled it because it was killing people. That same drug is the drug now across this country, is the only one that's being approved for people to take in the hospitals, and it is killing people. We have people that have gone to the hospital. Every single one of them that refused it is alive today. Everyone that we knew that took it and didn't listen to us, all of them are dead now. So this same dangerous drug, according to this bill here, it will allow Maryland to pretty much force everyone that it decides that has come with a positive test for this particular type of thing to have to take this. That's just premeditated murder when we have the information about this drug and the damage that it's doing. And the last part on the pedophile thing, because I think is important. When you have a bill that tells you that parents don't have a right at 3 years old to know or consent before you give a 3-year-old child an injection that the parent doesn't know what it does, what it is, and can't even determine if they've gotten it, you're sending the message that Maryland is saying parents do not have rights to protect their children. Anyone out here who has a desire to do harm to children would see this. If parents can't protect them from that, what allows parents to protect their children from anything else that could do harm? And so we see this as an opening door for people who are sexual predators to come after children and say, Maryland has given the endorsement, now you can go after children. It's safe because parents do not have authority to protect their children in the state of Maryland.
Thank you very much. Okay, we are now going to Adrian Belthuis. Oh, yeah. And you have signed up also on both the bills. And you know, our brains are getting foggy now, so if you don't all tell us everything you had on in mind, but your main points, that would be helpful so we can really take it in. Okay.
Thank you, Madam Chairman. I'll be brief. I oppose SB 839. Many of the people in here will spin these wild conspiracy theories about how vaccine passports are going to be some new mechanism to enslave us. I oppose this bill because it's titled as mandatory or voluntary. Clearly, this should be mandatory. Clearly, the point of these is to root out the problems in our society. You may be aware that right now in Maryland, there are hundreds of thousands of people still walking around unvaccinated, spreading their filth and taking up space. These are the people that we must address. Bills like this are required for us to find the ones who remain out there despite all of the efforts, despite all of the propaganda, and they remain unvaccinated. Without technology like this, we will not be able to find them. Let me give you a good example of how we can solve this problem. I got this today. This is from the local animal shelter. This is a little tag here. It shows the vaccination status of my dogs. It has a nice little QR code on it. They know exactly the status of my dogs. We don't need technology. We've got great systems in place right now where people can easily identify their vaccination status with a QR code built right in, and we can be clear who's in the club and who's out. I really encourage you to think more broadly about the problem here and to really get ahead of those who want to cast aspersions at our broader goals. Marylanders are full of fear right now. This is an opportunity to move forward. This is an opportunity to put in solutions that get us to our real goal. We cannot build back better when there remain folks out there who refuse to participate. We cannot establish the reset that we know is coming when we have all this resistance. It's up to you to change this, not voluntary, but make it mandatory, just like you know it will be in the future. Thank you. I yield the rest of my time.
Okay, good afternoon, committee members. My name is Cliff McDougall, and I'm a concerned father and longtime resident in Maryland. I work in the data center technology industry, and I'll just tell you, our personal medical data will not be safe with this proposed centralized vaccine passport system. There is numerous data breaches over recent years, documented in HIPAA Journal, that shows just an ever-increasing data breaches that this would be susceptible to. In regard to 840, this was an emergency bill in the past, and it should not be extended further. It should be ended now, frankly. Relatively, the pandemic is over, and this bill is basically all over the map with regulations for qualifications, for employment in nursing centers, for reporting on testing centers, on the ability to pharmacists to administer vaccines. All these things should be considered separately with careful debate, not all thrown in one bill. Most alarming in this is in 840 is that pharmacists are not doctors, and they're being granted the authority to give vaccines to 3-year-olds, like we've heard. Vaccines should be given after informed consent and consultation with the parents and the pediatrician. Those are the people that understand the health history of the child and what the implications are of giving the vaccine. We should also not incentivize people to get vaccines, like it says in section D5, but promote careful consideration regarding individual health histories. Pharmacists are just they're too busy already. They're not equipped to give proper post-shot care or respond to any adverse reactions that might happen. It's not what they're trained in, it's not what they're doing, and they don't know the past history of the child. This is a slippery slope. The most egregious part of this bill, I think, is letting pharmacists or their technicians administer vaccines to children, and it lowers the age from 11 to 3 years old. There's no mention in here of the requirement of parental consent, and like I said, it should only be administered by a pediatrician familiar with the child's health history and after full informed consent. These children also are at essentially no risk of dying from COVID. There's also in the fiscal and policy note for SB 840, it points out that the increase in the fiscal 2023 budget will be $2.6 million to implement what they're trying to do in 840. And it also shows, it notes that usually a contract like this takes 12 to 18 months to put in place.
Okay.
I just think that, I mean, the other gentleman made a great point about the cumulative deaths of vaccines in the past and what we have seen since 2001 with the rollout of this vaccine, and those cumulative deaths are eclipsing all of them in the past added together. We've got to be looking at this with a systematic solution, and I strongly oppose this bill, and I ask you to vote no and prevent this from moving forward. Thank you.
Thank you very much. All right, we're next going to Esther Szabo, and you have signed up unfavorable on both bills. And you guys are giving us a lot of interesting points, and it's sort of accumulating. If you think of things you thought of that have already been told to us, especially 2 or 3 times, tell us just about the ones, if you can, that we haven't heard yet. Thank you.
Thank you so much, Madam Chair. I do appreciate your patience with us and your professionalism. My name is Esther Szabo, and my former one of the testimony making a testimony. She's from Romania, I'm from Hungary. I am opposing Senate Bill 839. So I grew up in Hungary, and that was a country where citizens didn't have many rights. They had only limited access to products, services, information, technology, as well as travel outside of the Soviet bloc. We could only get a visa once per every 3 years to go to the West. In 1990, that changed, and the Berlin Wall separating East and West Europe fell. I first time came to the United States in 1990, after my country and the Eastern Bloc opened up. And I lived in the US, and I also lived in Germany. I found a much freer and system, and with a wide variety of choices. And I would have never imagined that in 2022, we would be talking about a digital system that keeps track of and allows just about anyone to see an individual's health record, which is a personal private information. And that based on such record, some would be limited to access certain services in Maryland. And I did hear the gentleman saying that this is voluntarily, but my experience with voluntarily. This year, my 2 children at the University System of Maryland were mandated an emergency authorized vaccine. It was not voluntary. They actually had to get it. My son had COVID. Many of the students who were in the sororities, in the fraternities at UMD, had COVID themselves. Health officials from the university and the Children's Hospital, PG County health officials came and told these kids who had no risk of dying from COVID, even if they had COVID, they should take a vaccine. This is against any normal scientific fact. These people had actually mandated vaccines to young children these are the healthiest segments of our society. That should have never happened. And recently I actually had heard that our esteemed senator who is introducing these 2 bills had something to do with it. Truly, to me, this is genocide. This is something that it should have never happened. When I read the email that came from the University System Maryland, I could not possibly believe it.
Let me butt in and say this. The fact that you guys are here telling us what you think is very important. And so thank God we're in a country where you can speak and tell us what you think so we don't vote not knowing.
Thank you so much.
Okay.
So these vaccine passports might be voluntary today, but it can be turned around overnight. And I experienced that. I also I lost my job over this because I didn't want to get a vaccine. So basically people, little tyrants in petty positions that work for nonprofits, all kinds of organizations, had the required vaccine for hiring and firing purposes. Okay. That is unconstitutional, it's discriminatory, it's segregatory. Everybody in this country got so scared of COVID that they didn't want to see their colleagues anymore if they didn't want to take a vaccine. That is something that should not happen. So I respectfully ask you to vote against 839.
Thank you.
No,
Thank you very much.
840 is a bill that has many elements in it, and some of the other people testifying here mentioned it.
Could you just give us your main points? We've got several more people to
Yes,
get to. And we got
I do.
another bill that a person is waiting for also. So we get the sense that the majority of people in the room don't like these two.
Exactly. Yeah, thank you. So basically, sound medical practice is that somebody has a symptom, then they go to see a doctor, and the doctor will establish that they have a symptom, then they order tests. This is how it happened until 2020, when it all changed and people were told not to go to see a doctor, to stay at home, and then if they already are not able to breathe, then they have to go to the hospital. that we didn't know nothing about this so-called virus, but overnight we could develop a vaccine in 9 months. So many people just don't believe this. And unfortunately, censorship has happened in this country, and there are many people who are actually not understanding how come that we cannot have a scientific debate about how this is all happened, and why are we not allowing that. And yes, as Alexis also testified, companies had stopped funding, stopped all kinds of services to people and organizations who were basically not believing the same thing as the so-called narrative was.
Okay.
Can I just say, as far as the pharmacist bills, I'm against that. I have recently been to a pharmacy. I got a prescription from my doctor. When I went home, I didn't see how many times I have to take the antibiotics. So it was the end of the day. I didn't want to call my doctor or my pharmacist. So I went on the internet and I figured out that I have to take, twice one pill. But this is just such a mistake that happened between the pharmacist or my doctor. I don't know. But this was simple for me to solve. But a 3-year-old be vaccinated at an order by a pharmacist who's very busy. We all know what's happening in CVS and all kinds of other places where we go. So I respectfully ask to vote from you to vote against this bill as well.
And thanks for your testimony. We're going now to Esther Szabo, and you've signed up. Let's see, no, that was Esther. We're going to, just a minute, to Julie Sharp. And you signed up on both.
Good afternoon. Bodily autonomy is fundamental. What I do to my body should be my choice. But this bill wants to take a little bit of that autonomy away. It's not blatant, it's voluntary. I can choose to do something to my body to get the vaccine. I can choose to carry proof of that. It seems convenient what this bill is recommending. I don't have to worry about losing my card. But there's a trade-off that I don't want to make. The passport enables my freely given, happily willing, uncoerced medical compliance to be linked with social freedoms, like going to a restaurant, or financial freedoms, like whether I can have a job. And for a person who chooses not to get it, we don't want to create a segregated society. Of course, businesses should be able to make their own rules. They should be able to decide if they want to or don't. But it is not right for the state of Maryland to enable that discrimination, for taxpayers to fund the system that facilitates that discrimination. It's what this bill is proposing to do. Passports have been tried in other places and rejected. Montgomery County, it's already mentioned. And New York City is ending their passport system on March 7th. Israel is abolishing their passport system because, this is a quote, "To continue the green pass can create false assurances. It is not reducing infections. It's not working." In case Maryland wants to use it to maybe boost numbers, we also learned from Israel that it's been ineffective at encouraging vaccine holdouts. Instituting a passport system locks us into a solution whose need has passed. COVID metrics are on the decline. It's not urgent any longer that we take away and shut down. Thank goodness we've arrived at opening and freeing, so I ask you to vote no.
Thank you.
And for 840, I continue with my concerns about the vaccine passport. Sorry, you've heard a lot, but the more we reinforce, the more you're convinced.
We've just got to get to other people.
Yep, okay. I'll choose some things. We haven't talked about this. Other concerns. If Maryland institutes a vaccine passport, for now it's about COVID. We might be fine with that original intention, but how many boosters are enough? The Washington Post reported that booster effectiveness declined substantially after 4 months. Israel found a 4th dose insufficient. So you might have been fine with 1 or with 2 or 3, but what's the end point? There's not an end. It can add, this bill allows any CDC-approved vaccines to be added to the passport. If I don't comply, will my passport go invalid, or will I be forced to receive shots to maintain my ability to function in a world we created by setting up this system in the first place? And why? Or will anyone who doesn't comply be relegated to the other tier of society? We've talked about that. How does discrimination align with our values of equality? What about passports for our children? Parents are reasonably cautious to volunteer their kids for a medical intervention with unproven long-term effects. We are waiting unless a passport system forces our hand. Coercion like this does not feel entirely about health, though. A passport system, I'm not going to repeat that. Essentially, the end of this is, my sister lives in Manhattan. She recently ate at a restaurant where her husband and she were asked for their papers. They showed them, but she said it was very uncomfortable. She said showing our proof of vaccination feels like an echo of a cautionary dystopian novel, not a preferred progressive future. That's it. Thank you.
Thank you very much. Okay, we're going next to Agni Pack, and you signed up also for both bills. If you could condense it as much as possible,
Yes.
we'd appreciate it.
So one thing that I couldn't prepare for, I guess everything else you can read in my written testimony, which mainly deals with the technology aspects, but HIPAA, I've had 3 previous surgeries, and I don't want to go into it. I don't think COVID vaccines help because I did have to go to the ER, but HIPAA regulations, which the Senator Rosa Pepe incorrectly mentioned that family members can know your history. That is not, I don't believe that follows HIPAA. HIPAA follows that you have to consent which family members know your history. So as a concerned citizen, if you open the Maryland Department of Health website, you will see that the Immune website lists that they're experiencing a network security incident involving the Maryland systems, and these have affected our local health departments. On December 4th, 2021, incidents led to hearings held in January earlier this year that alerted us to being in ransomware attacks. How many times I have heard about being with cyber that ransomware attacks happen, and we usually sometimes even pay them off, as happened with the energy industry. The FBI also alerted us earlier regarding QR codes. QR codes have been used more in restaurants where you scan and you can actually be redirected to websites that are malicious, and the FBI released an alert. I have given the number in my written testimony, but I believe it was January 18th when that PSA was announced, that QR codes are not necessarily worthy of security, as Rosa Pepe mentioned. Also, the 117th Congress of 2021 to 2022 introduced the HR 5936 Ransomware and Financial Stability Act of 2021 to include requirements relating to ransomware attack deterrence for a covered U.S. financial institution that is in the Consolidated Appropriations Act of 2021. So what about regular people? If we have a QR code that we're redirected to and we have ransomware, and I mean, the Maryland Department of Health has money to order 3,000 additional laptops, who's going to pay for us and our COVID vaccine reactions, and we don't even keep data, or it needs to be updated and it needs to be in bills. Also, I want to speak to 840, and really quick, the most egregious part of this bill is that it targets children as young as the age of 3. I did write that the former head of the FDA and now director of Pfizer, Dr. Scott Gottlieb, has delayed trials and shots for kids under 5 due to their low COVID cases, as they are not symptomatic. So we're not even doing trials on children under 5, and we're expected to inject them as young as 3, according to this bill. Does Maryland care about its kids? Do they even care about any reactions that are possible? Thank you.
Thank you very much. Okay, now we want to hear from Jenna Butler, and you signed up also on both bills. And if you could be as concise as possible, we appreciate it.
Yes, ma'am. Thank you.
Okay.
Thank you, Chair, Vice Chair, members of the committee. My name is Jenna DeCiceres Butler, and I'm a parent and small business owner from Annapolis, and I'm here in strong opposition of SB 839 and 840. Many points have already been covered, so I will try to summarize. I first wanted to address a comment of Senator Rosa Pepe's. Last session, we were in a completely different position, and to my knowledge, the necessity of the previous version of 840 was not widely opposed. We know more about what works and what doesn't now. Excuse me. These bills and the policies they would encourage are not supported by science, and they are not supported by the public. I want to stress that I am extremely concerned, given our different position from last year, about the expansive scope and impact of 840. The sheer size of this bill violates the spirit, if not the letter, of Maryland's prohibition of omnibus bills. I think it is confusing for the public who would be paying for all of this and who these policies would directly impact to follow, and it requires much more time and thought than a typical piece of legislation. As you read through the bill, we have the continued COVID response planning from last year, as Senator Rosa Pepe mentioned. And then as you go on reading, we're getting into things like vaccine passports and pharmacists vaccinating children. This does not make any sense. With 839 and 840, funding and encouraging discriminatory policies is just as bad as enacting them. Businesses and people who want to do this, who want to provide vaccine proof, have already figured out how to do it. If a business feels like they can provide the needed staff to check vaccine proof, they have already done it. They don't need any more tools. There's no need, and it is actually inappropriate for the state to be providing, endorsing, and spending almost $3 million on a tool for this. In regards to 840, the topic of pharmacists vaccinating children needs its own hearing. And in fact, I've watched this very topic be debated here more than once. This is not a safe practice. It is not supported by pediatricians or parents, and it absolutely should not become a permanent policy in Maryland. It is unnecessary, unsafe, and deprives children of the comprehensive medical care that they deserve. It is nothing more than a financial boost for pharmacies. I urge the committee to give an unfavorable report on both of these pieces of legislation. They are fiscally irresponsible, they are not evidence-based or supported by the public, and it is more critical than ever right now that we save our funding dollars and our precious public health efforts for effective initiatives that will actually help our state move forward. Thank you.
Thank you. All right, we have two last persons. Each one signed up on one bill. I'll ask John Kelly to come up on 839 and Laura Hartman on 840. All right, you have 2 minutes each.
Okay. Good afternoon. Again, my name is John Kelly, and we'll try to be brief. The previous people who testified had made several of the same points, but the analogy that was used in the last hearing that you had was brick and mortar. And just to emphasize what this bill is doing, the bill has a seemingly innocuous title and purpose that masks the underlying fact that it is the mortar for the bricks of failed state and federal policies to address COVID-19. The bill facilitates the continuation of these failed policies, one of the most pernicious being vaccine passports. The policies laid waste to the economic lives of thousands of Marylanders and millions of persons across the country. They have damaged instead of promoted the public health and social coherence of the country. At the same time, they came with unprecedented infringements on personal liberties. The alleged voluntary aspect of the bill provides a choice on how a person wants her or his invasion of privacy and infringement of civil rights to be monitored by a mobile application or by a paper document. As a practical matter, people have mentioned the pandemic is over, and states, cities around the country are getting rid of these requirements. So Senate Bill 839 is swimming against the tide and swimming in the wrong direction. On one thing that hasn't been mentioned before that I think is very important, one of the most important roles of a legislative body is oversight of the executive branches, executive agencies in the government. The time is long overdue for the state's agencies in charge of COVID policies to explain and justify the COVID policies of the past 2 years, especially in regard to any role that they may have played in censoring scientific and general debate on COVID responses, suppressing safe and effective COVID treatments, and infringing on the civil liberties of the citizens of Maryland. Thank you.
Thank you. All right, and Ms. Hartman, you're going to have the last word.
Last but not least,
840.
right? Hi, my name is Laura Hartman. I'm a lifelong resident of Maryland, and I'm here with you today. When I read this bill, it scared the hell out of me. I have 2 boys who are 12 and 14, and under no circumstance would I feel compelled to consider making them part of a medical experiment. There have been thousands of calls and emails to Senator Rosa Pepp's office about parents' concerns, and yet still he pushes this bill forward. I find it interesting that he said that he wanted to have this hearing to hear our concerns, yet he left today. We don't know the short and long-term health effects of these vaccines. And we know that for children especially, that's 99.8% survivable. My husband and I thought long and hard about what we would do because we were concerned about our community, our friends, our family, our parents. But the risk of myocarditis in boys is 1 in 50 from getting this vaccine. Myocarditis is not treatable. It weakens the heart muscle, and there's no turning back. A few quick questions for you. Why would we include the State Department of Education in this bill? Are they all of a sudden knocking education out of the park and have free time? Why are we sticking to the narrative that COVID vaccines are good for every one of us? As of last week, 1.9 million people reported adverse effects, and 24,000 people have died from this vaccine. I guess ultimately this bill is riddled with coercion, enticement, and it circumvents the traditional doctor-patient and parent relationship. The scariest part for me is with this bill, you take away all parental rights. Any person in this room could take my 3-year-old into a pharmacy and get them vaccinated. And again, to everybody's point about the pharmacists, they're no more qualified than my doctor. They don't have the equipment. They don't know how to handle adverse events. They have no system in place to mitigate risks or mistakes. How many times have you gotten the wrong prescription? Or, there's a slew of holes in this. And as the great Dr. Malone has always been quoted on, where there is risk, there must be choice. I'm asking you to vote no and not move this legislation forward.
Okay.
Thank you all for listening to all of us today.
Sure. And I want you to know you have been heard, and that's why we're here, to find out what the public thinks on these bills, and we take seriously your testimony. We can't always make everybody happy, but I think it's our responsibility to hear all sides, and you've been very clear with your positions. Thanks so much for testifying.
Thank you for hearing all of us.
Okay.